the notable figures came out was that 71% of ENT surgeons did not ever advise CBCT in their practice. Only 25% knew CBCT requires lower radiation dose. Only 25% knew spatial orientation is better in CBCT. 75% knew that CBCT can be used in the diagnosis of obstructive sleep apnea. 62% did not know CBCT can be used in imaging sinusitis of dental origin, and 18% agreed that CBCT had potential to replace conventional CT in ENT imaging in the future. So those were the notable facts after this survey. So when I critically reviewed this article, then I thought it is time that the CBCT, the CAT surgeons should embrace the CBCT technology. And my success story itself was a testimony to share this. And for this purpose, I thought we should organize a workshop to popularize the cone beam CT scan technology and take the benefits of this cone beam CT scan to our patients. And I call the dental surgeons as our big brothers in the field of CBCT because they are using this since probably decades. The simple reason that here is the natural contrast around the structures we are both interested in. If air is around the structures, then CBCT is the scan. As you agree with me, the dental structures are surrounded by air. Media contains air, mastoid contains air, nose contains air, paranasal sinuses contain air. Then it is CBCT is ideally suited for the field of ENT. So to discuss various aspects of cone beam CT scan, we have expert speakers today. We have Dr. Anand, who is the CEO of Tenet Diagnostics, who has done MD Radiology. Dr. Suhas is the oral medicine and oral radiologist. He is professor and head of the Department of Siddhartha Medical College, Tumkur. Dr. Shreyas Pradeep is consultant ENT surgeon at MENTS. Dr. Shilika, she is a dental surgeon and an entrepreneur from V-Scans is here. And Dr. Srinivas Dorisanga, he is an ENT surgeon and well-known figure in the field of vertigo, and he is with us. And myself, we are all here to share our experiences with you. And I want the whole program to be interactive. You can ask questions at the end of the session to the speakers. There's enough time. If you have missed any questions, then again there's a question and answer session later in the day. And now we'll start the academic ball rolling by writing the line. I request the speakers to come forward and write the line. Right, so, so we have lined up an interesting agenda today. The first, so the topics have been selected such that some are general topics which are useful for both the EAP surgeons and the dental surgeons, and some are focused on the dental topics, and some are EAP topics, so that everybody will have benefit out of this workshop. And after the lunch, we are going to have the live demonstration of the software also. So as I had told you, people have brought their laptops, they can have the live feel of the software. Otherwise, also here we are going to demonstrate live this thing. And we can also show one of the recorded patients how the CBCT can be done on the patients. And now we'll start the events, the action program. The first speaker will be Suhas. So it's my pleasant duty to introduce Dr. Suhas. The first two lectures he has got, and he will combine into one lecture. And it's a topic, it's a general topic which will be beneficial for both the ENTs and the dentists. Dr. Suhas, he has done his BDS from Manipal University and MBS in 2000. He did in oral medicine and radiology. You can see he has got 25 years experience. Okay. And he is a clinician in the oral medicine and maxillofacial radiology with special interest in oral mucosal lesions, orofacial pain, including TMJ disorders, and a career academician. He has interest in research, and the areas of interest are management of chronic oral facial pain, oral potentially malignant lesions, and radiation biology. And he has a, I have to shorten his biodata, and he has authored a chapter in orofacial pain, the clinician's guide. Okay, and right now, he is professor and head of the Department of Oral Medicine and Radiology from Siddhartha Medical College, Tumkur, and also is director of postgraduate studies, research and development in Siddhartha Institute of Medical Sciences. And I see he has a lot of publications to his credit, and also I see that he is called in both national and the state conferences to deliver a lot of lectures to share his experience, and he's also chairperson in scientific committees in the national and also in the state conferences, and he's with us to uh, share his experiences with one being stand, and I welcome you. Thank you.
Thank you, Dr. Pradeep, for an opportunity to be on the topic. So today I'll be sharing with you few insights on the basics of CBCT. This has been prepared partly a technical input and partly for a clinician modification. Because as clinicians, we should be aware of certain technical issues, but we should not be as an expert in the technical issues. Now, that's the CBCT problem. Of course, the lady is not a part of the CBCT, but to give you a perspective of how big the machine is. So, by name, we have a acronym as CBCT. It stands for Cone Beam Computed Tomography. It is basically an advanced imaging technology wherein the element of third dimension is brought in with ease. By bringing in the third dimension, we have had a lot of advancements in the way we perceive the diseases or the anatomical structures. So what are the key features we need to look at? Now, the name as such, it says the X-ray beam is cone shaped. That is one of the key features. When the capturing of the image is a rotational capture. Why rotational capture is important to understand, I will share sometime later. And then once the rotational capture is done, there is an option of 3D reconstruction in different planes. So how these different planes, by reconstructing, how we can look into the final details is what I'll be sharing with you in the next few slides. And the applications of the CBCT is mostly in dentistry, AFP, maximum pathology, and even in orthopedics, it's picking up. The first concept we need to understand with CBCT is the hardware of the image. Very briefly, there are three components. The source of the energy is the general radiation, what X-ray produce or told earlier. The source is the same. There is no change in the source. Ionizing radiation, an important point to note. Then you have the gantry. It is a fixed CR, and then the detector. Detector is mostly the latest ones are CMOS detectors. CMOS stands for complementary metal oxide scintillators. The advantage of the receptors here is that we get distortion-free images. Generally, when we look at the pathologies or the anatomy, only when we try to understand the structure is a 1:1 scale, it gives us better inputs as to what is the extent of the lesion or the changes in anatomical variation, this kind of. And the most important thing is the field of view, FOV is what is called as, which otherwise is not available in the other medical 3D imaging technologies where the entire body or the entire organ is exposed to radiation. So these are the key features of the hardware in the CBCT. Next is the image acquisition. A picture to compare regular CT scan, medical CT scan, and the cone beam CT. Picture A is the cone beam, and picture B is the medical CT scan. If you see, the position of the patient is different here, and in the regular medical CT scans, you have a fan-like structure of the radiation, which rotates around the head. The advantage, disadvantage of these two is when we look at the fan, the acquisition of images data is anisotropic. The volume of the data is in different dimensions. It is not uniform. That becomes a negative part in the fan beam scans. To make you understand better, the field of view. So if you see here, not the entire skull is not exposed to radiation. Just the part that we want to see is exposed to radiation. This is a game changer in the technology where the concerns of issues with radiation exposure, unnecessary exposure, is minimized to a large extent. The field of view can be adjusted according to the structure used. It need not be the entire skull. It could be as small as 1 or 2 feet. When we come to the understanding of how the data is captured, here the data is captured by rotation. The gantry rotates around the skull, and from all dimensions, the data is collected. And when it is pulled up, it looks like a Rubik cube structure, where each cube contains information of the particular anatomical region of the skull. Okay, and the advantage here is each of this is having the same dimension. The cubes here in this data are of the same dimension. How it is useful is when I share with you the other share slides, I will tell you how it makes it. So the major advantage of the CBCT is we can record the anatomy of the maxillofacial region in 3 planes of sections. Now, which are the 3 planes? All of you are aware that these are the 3 planes: the axial plane, the sagittal plane, and the coronal. This is very similar to the CT scans which give out different plane structures. When you start using the software to analyze the information, these 3 planes will form a major basic understanding for you. Only when you orient the images to these 3 planes, you will be able to understand how manipulating the image in oblique planes will give us input. Initially, when we manipulate the image, it's kind of confusing because we are not used to seeing the anatomical structures in very different planes. But when we start using the software, you'll understand how unique and how beautiful it is. The concept of field of view, FOV. See, when we take a radiograph in the conventional system, the entire image is in one plane. Here, the data what is acquired is cylindrical. The region of exposure in the skull is cylindrical. So by reducing the height of the cylinder or increasing and decreasing the diameter of the cylinder, you are changing the position of the source, wherein you will record only the structures inside the cylindrical structure. The structure which is even half a centimeter outside the cylinder is not recorded. So that is the fineness with which the data is recorded. The major advantage of this FOVs is that when you want to see a small part of the skull, the dimension used is a very small dimension, wherein you are sparing the rest of the structures from unnecessary exposure to image. Artifacts are inclusions in the data which are inevitable in many circumstances. We need to understand the artifacts, and we should be able to perceive the artifacts because many times these artifacts can be misconstrued as pathology. So there are many artifacts, but I'm sharing with you a few important ones which can make a difference in the diagnostic process. We have something called as a beam hardening artifact. What happens here is when the radiation source is used and a very dense structure like a metallic structure is in the path of the beam, the area right adjacent to the metallic structure appears extremely dark. The problem with this is it can be misunderstood as a pathology. For example, in the picture on your left side, you have a section of a tooth which has undergone a root canal treatment. The straight wire-like structure, what you see in the tooth structure, is the root canal restorative method. And when you look at the anatomy of the tooth has canals in it. Now, here it mimics as if there is an additional canal in the tooth, which can be understood as unfilled portion of the canal or a missed canal. So, like this, there are many artifacts which can be construed as a pathology. So, we should be aware of the artifact. That is the importance of understanding of. Similarly, in the picture to your right side, it is again in the root canal vestibular section. It is an axial section. If you see, there is one cylinder, dense cylindrical structure in which is adjacent to the root canal. So the portion of the dark portion what you see cylindrical is the unfilled portion of the canal. There is a radiating black line which is running across the tooth. This is again a streak metal artifact which can be misunderstood as a fracture in the tooth. Another example of streak metal artifacts. The arrow points to a missed filling in the root canal. When a radiograph is done, generally the technician instructs the patients to remove all the earrings, chain, clipping, etc. But sometimes if it is not removed, then we see artifacts from these structures as well. The radio structures what we see here are from the hoop earrings which the patient is being aware of. The best part here is the structure which is causing the artifact is not in your field of view, but it's outside. In spite of it being outside, it is having an impact on your field of view. So it is absolutely important that you need to remove any ornaments or metal structures to be here. Most of the ENT patients who have hearing disability have also the device around the ear to increase the hearing. Even though this instrument is outside the field of view, it can also bring in artifacts. You can see those strays running across. This is caused by the device which is worn outside. Okay. If you recollect the image of beam passing through the skull, the FOV is in the center, but there is the radiation that is passing through the skull, which is passing through the ear. So any metallic objects here can cause a artifact, okay, even though it is not in the FOV. Once the data is captured, it is collected in different formats. The most common format is the DICOM format, which stands for Digital Imaging and Communications in Medicine. It is a standard format which is used in medical technology as well, wherein you can read images or data from any of the captured machines. Then the raw images, which are the best when you're using it for manipulating the images. Then the other forms are that if JPEG images. These are used to capture the data to generate reports. They will not be used for manipulating the data to see them across imagery software, but they are used for generating reports. So these are the file formats, and all these file formats are bundled into a viewer, okay, which generally is given along with the scan. So you don't have to have a separate purchase the software, and the vendor who's giving you the scan is going to bundle the viewer along with the data. So you should be comfortable using and opening the software and using the program. Then the image reconstruction. So here, the technical term used here is a filtered back projections. Okay. This is where the technology has given us a thumbs up here. The data that is captured are in isometric voxels, means the cubes are of same dimensions. The advantage of having the cubes of same dimension is when you cross-cut these cubes in any dimension we have, the volume structure remains the same, so that the image distortion in the views what you see is absolutely minimal. Otherwise, what happens is the image will get either elongated or shorter. But with isotropic volumes, there is no change in the magnification of the image, irrespective of how we slice it. So to briefly understand how the rotation works here, so if you see an image taken with 2 projections, 3 projections, 18 and 20 projections, the beam overlaps so much that with the original structure, when there are images captured with more degrees of rotation, you are absolutely eliminating any geometric distortion. And that is what the CBCT brings. It has 180-degree rotation, and sometimes some machines have a 360-degree rotation also. The fourth concept is the image visualization. Now these are the key features here. Okay? Now here creates a 3D matrix from a series of 2D images. Okay. Then there is something called as a multiplanar reformation window, also called as the MPR window. This is where we can adjust the plane in which it is sectioned. Then we have formatting in terms of oblique and curved formatting, which is not available in your regular medical CT scans. The skull structure is kind of curved, especially in dentistry, the jaws are curved. So when we want to visualize the jaws which are curved in a flat plane, this helps us in reformatting. So the reformatting can be done in oblique as well as curved planes. And we can also synthesize panoramic images. Normally, the technology for recording a panoramic image is different, but here we can do synthetic generation of panoramic images. I'll show you how it is done. Now, this is the view in the software which has the LPR reconstruction. If you see this, there are 4 different boxes in the software which is provided by the Madurai company. The connotation says the red color stands for the coronal section. In the corner, you can see a colored mark. The red mark is for the coronal section. The green mark is for the sagittal section, and the axial plane is in the blue mark. Okay. If you cannot remember the names axial, coronal, sagittal, then you orient the image. Looking at the color codes, you'll be able to figure out in which plane you are manipulating the image. Then you have a 3D structure here in the left lower bottom. If you look at the 3D structure there is a color plane. Each color plane denotes this, whether it is the axial plane or sagittal or coronal. So you can orient the plane in the 3D section also. And you have an option of eliminating 1 or 2 planes in your visualization in the 3D structure. So you don't want to manipulate in coronal plane, you eliminate the coronal plane, so you visualize only the axial and sagittal planes. So that is the advantage this software provides. But for you, for the initial understanding, the image is in 3 planes, which are the axial, coronal, and sagittal. In the perpendicular planes here, the visualization is easy because it is very similar to what is studied in anatomy. But once we come to oblique reformation, here in the reformation, what happens is, if you see, the 2 planes which were earlier in a more coronal section has been shifted. By shifting this, the sagittal section, the entire skull is visible, the jaw is visible in one plane. But if you see the coronal section, it is distorted. This is your coronal plate. In the previous section, this is your coronal plate. So you can see one proper slice. But here, because it is obliquely rotated, this is how it looks. So here, the coronal plane, which is on the side where the sagittal is, the distortion is minimal. The side on the opposite, the distortion is more in terms of visualization. But anatomically, it is the same 1:1. Then we have curved reformation. So here, if you see, we have marked out the curved structure. So the entire structure in that yellow line is visualized. The rest of the structures, which is in front or back of the yellow line, is not recorded there. The advantages of this curved reformations is you can change the curve to see whichever part you want to visualize. At the same time, we should be careful in understanding this because in people who are used to 2-dimensional imaging structures, these areas in the where it is blurred out, that can be misunderstood as a pathology. So you need to see whether the image is reconstructed in a curved plane to understand whether we are looking at anatomy or pathology. the different width of the curved reformer. If you see the 10 millimeter structure, in the anterior region, it looks as if there is a cyst. So if you are not aware that the reformatting has been done in a curved plane, this can be misunderstood as a cyst. So we'll increase the width here from 10 to 20 mm. The blurring in the anterior region has become very minimal, wherein we appreciate that there is no pathology. If you see the right lower mandible, in the tooth, there is a radiolucent lesion. The radiolucent lesion has always been in the focal curve. So there is no distortion there, and that is a pathology. Whereas the anterior plane, where it is out of the curve, can be misunderstood as a pathology. So the kind of reformatting that you are using to visualize is what you should be aware of when you're looking back, manipulating the image in different units. Then the major advantage of the CBCT is you can have perpendicular planes. When you have a curved plane, in the curved plane, you have a perpendicular plane to the curved plane. Okay, this we call it as paraxial sections or as cross section. This we majorly use in implant planning in dentistry. Dental implants are metallic structures which are embedded into the alveolar bone, which future forms the root form of the tooth onto which the crown is placed. So for placing that, we need to understand how much of bone is available to place the metal structure. So this is another advantage of CBCT in dentistry. Apart from this, there are other visualizations which are useful. 3D rendering. With the advent of 3D printing, we can do 3D rendering. The advantage of 3D rendering in CBCT images is that the surface rendering of 3D images, which is useful when you're going for implant surgeries where you prepare a guide for placing the image. So for these structures to be fabricated outside the mouth, which uses data from the diaphragm images, we need to have a surface rendering. So the entire 3D structure is visualized, which can be used for 3D printing. Whereas the volume rendering of 3D is not useful for preparing the surgical guides. So in the CBCT data what we have captured, we get both volume rendering as well as surface rendering. Volume rendering is what we visualize when we are seeing the images. Surface rendering is when we use it for sharing it with third parties to prepare surgical guides. When we look at the screens of computers, what we use for visualizing this, the best suited is 1920 to 1080 pixels. Anything lesser than this, what happens is when there is when you try to view, even though the data is captured in isometric cells, when it is viewed in the screen which has a lesser resolution, these images get distorted and they appear as if it is not isotropic but anisotropic. So the best viewing, you need to have this minimum resolution on your computing monitor. So there are some challenges with the interpretation process in this industry. Major one is the misinterpretation of artifacts as pathologies. So for this, you need to be absolutely aware of the different artifacts. What I've shared with you in the previous slides are just a few, but there are many more there. And then there is a problem with the over-reliance on retail reconstructions. Because it's a fascinating tool, whenever you get a new tool, you start playing with it. And this tool is extensively used by clinicians to try to make the patient understand about the pathology. Again, if the clinician is not well-versed with 3D manipulations, it gives a kind of false promises to the patient. Another major disadvantage is the soft tissues cannot be visualized. In your regular CT scans, to a certain extent, by changing the litho levels, you'll be able to see some soft tissue structures, but where soft tissue visualization is absolutely minimal. And then you need to be continuously on the program trying to do it on a daily basis, because it is something like using your cell phone. each day when you're using the cell phone, you're discovering a new feature in your cell phone. Similarly, with the software here, there's so much advancement. The basic training, what you do get on a hands-on tutorial is very basic. When you start using the different tools, you'll understand the capabilities of the software, which is much more than what it looks like. The next portion of the presentation is the second portion where the concerns about radiation exposure to patients is to be discussed. Now, as we all know that the source radiation here is the same ionizing radiation which has been used in X-rays. How much of this it is safe? Is one exposure okay? Two exposure okay? Difficult to extrapolate because we have something called as a stochastic effects. Stochastic effects of ionizing radiation is with each exposure there is a possibility of accumulation of radiation-induced damage. There is something called deterministic, means whenever there is radiation exposure, there is a definite damage which happens at very high doses. But with diagnostic radiology, most of the challenges is with the stochastic. So there is always some kind of a damage to the cell that is happening because we are using ionizing radiation. So the statement given by the International Commission on Radiological Protection says the likelihood of impairing exposure, the number of people exposed and the magnitude of their individual doses should all be kept as low as reasonably achievable. As low as reasonably achievable, taking into account economic and societal factors. This is what they say. The major focus here is as low as reasonably achievable, means use it only when it is essential, and whenever you are using it, make sure that you use the smallest amount of radiation possible. Now, this is a general statement whether you are taking a two-dimensional radiation image or a 3D image. We always want the best looking images. When we take pictures, we want our pictures to look the best. Similarly, as radiologists, when we want to look at, we want the best looking images so that we can look at all the details and give you good look. But the problem here is to get the best result, we'll have to increase the energy in the radiation so high that it will cause a lot of radiation. So we need to strike a balance between the different factors that control the radiation beam so that we get an image that is easily readable with diagnostic information. Okay, so for this we have certain technical thing here: spatial resolution, contrast, noise, artifact, and radiation. When the field of view size increases, the radiation dose increases, the contrast increases, and noise increases. So like this, each of these factors contribute to the overall clarity of the image. So we need to strike a balance to make sure that we get a good readable image. At the same time, we have the empathy towards the patient so that they are not exposed to unnecessary radiation. Now, this table is a comparison of different exposures. Now, for example, intraoral dental radiation. Here, we use a term called as effective dose. Effective dose has got nothing to do with radiation, but an indicator of the associated risk. We cannot meter the dose to risk to an individual, but we can use it to compare between different types of radiation exposure. So if you look at the first row there, the intraoral dental radiographs have an effective dose of maximum of 8 microsieverts. As you go down towards the general CT or the CT of the working head and neck, it is 2100 microsieverts. You see the scale of radiation. If a dentist can be able to visualize the required information for his diagnosis using an intraoral radiation detector, he or she should stick to it and not avoid the CT analysis. At the same time, when you compare the radiation from small volume procedures, when we use FOV, small FOV gives 50 microsieverts, large volume flows 100 microsieverts. When compared to a regular CT, it is much lower. If you compare, say, of a large volume 100 microsievert with a regular CT scan, it is about 21 times higher than CT if you go for a regular CT. And the same data is available with the CT scan. You don't have to go for a regular CT scan. So this is where we are having an advantage in the sense not only for the patient, but also when we are looking at the image clarity, the spatial resolution is much higher in the CT scan compared to regular CT. OPGs is another commonly used diagnostic two-dimensional imaging. If you look at panoramic examinations, even there, the range is between 4 and 13 microsieverts, depending on the duration as well as the machine to machine variations would be. All said and done, here when we compare the radiations to the normal environmental radiation what we get exposed to. For example, one dental X-ray is equivalent to 1 day of natural background radiation. Panoramic examination is 2 days. If you extrapolate it to a regular CT of the skull or the neck, it runs to almost 3/4 a year. Okay, so this is a scale comparison for you as to how much radiation exposure is there compared to different methods. When we look at the radiation safety advantages with CT scan, the major advantage is that we can tailor the field of view, which will reduce the unnecessary radiation exposure. The duration of the scans as compared to the regular CT scans, it is very less. 14 to 16 seconds is what 180-degree rotation takes and captures all the required data for us. And there is ability to focus on specific region of interest. For example, in dental, we have only a problem in one foot, we focus on one side. ENT probably you have an issue with the right side, we focus on the right temporal zone rather than getting the entire right and left. And overall, there is a reduction in the exposure to radiation compared to medical science. These becoming the advantages in the research as a room of CBCT towards radiation protection, safety from unnecessary radiation exposure. In the CBCT, how we can further minimize the radiation exposure. All this. So using as small as possible, then you have an option of adjusting the resolution. When we are looking at scans for visualizing the root canal anatomies, we want a high resolution scan. If you are not looking for a high resolution scan, you can reduce the radiation exposure much lower so that you don't expose the patient to unnecessary radiation. And then apart from that, shielding of the patients, we can use electrons and thyroid colors. And most importantly, we need to get in touch with the technician on a daily basis, not on a daily basis, regularly. The daily basis, what I mentioned there was the IR machine what we are using as a daily check option. So in this, the software automatically checks for errors in the machine. Any error in the machine will not work further. Okay. So like this on a daily basis, you are ensuring that you are taking care of the needs of the patient from unnecessary radiation. And again, there are calibration components which the technicians can do it for you on a regular basis, whereby your responsibility of maintaining the machine so that radiation exposure is minimized. Again, we need to balance between safety and diagnostics. Being in the field of providing services for CT scans, what I've observed personally is whether the requirement was there or not, the patients have been sent for CT. So I personally request you to use CBCTs only when there is absolute requirement. If you can make good with only two-dimensional imaging, please do so. And then when you do follow-up images, Orthodontics, they look for tooth movement procedures. Earlier days, they used to rely more on clinical adjustments or two-dimensional imaging. Now they keep sending the patient for three-dimensional follow-ups. So in one course of orthodontic treatment, the patient gets exposed to 4 or 5 radiations, which again is not very healthy. Again, we need to stick to this as low as reasonable achievable concept, so that we make sure that patient is shielded from unnecessary radiation. So to conclude, we have CBCT, which is a smarter and safer choice. There is a significant reduction when compared to medical CT. In the technology, we have the options of optimizing the field of view as well as the energy used for radiation. So with this, we have a bone where we can diagnostically look at the finer aspects of the pathology of the animal. Thank you. Any questions? And open for discussion.
The radiation dose of I mean, there has been too much of talk, noise, and this thing. Was what we use is all medical diagnostic radiation. So you don't have to, as long as you use this, I think that is the key here. These technologies have been there for almost 50 years. CT scan has been there for 50 years. So my thing is, I mean, more like a Western concept, not to, because natural background radiation, people who are living like in Ramagram or whatever that way, that you have a high exposure to natural background radiation. So Kerala, places like Kerala or whatever, I mean, our bodies are more got used to it. And, as we know, our society requires the right diagnosis. Here, everything is paid by patients. Here, it is not by insurance penetration is less. So that's my take also in that way. I think I want your views on that. Not to really.
I agree with you. But the being in academics, I have been exposed to so much of literature. Now, there are literatures which have calculated by mathematical calculations. It is not a cause-effect calculation, it's by mathematical calculations. They have looked at brain tumors, occurrence of brain tumors before and after the use of diagnostic radiation. And statistically, the mathematical expressions say that the incidence has increased to a large extent. So, like this, there are so many are there. And then there are many cell-level studies. I was a faculty in Nepal, where I was working in the Department of Radiation Biology. Incidentally, I had registered for a PhD program, wherein I was interested to examine how much of radiation damage the OPG radiation causes. So here, what we had designed was to collect the blood before the radiation, culture the fibroblasts, lymphocyte culture, before and after the exposure. And in the culture, you arrest the cell cycle and look for DNA damage. This was the experiment we had set up. But before that, we did work on fibroblast cultures. Because the challenge I faced was the lymphocytes are circulating. And we don't know which lymphocyte was exposed to radiation. So that was a major field. So what we did was we replaced the lymphocytes with the fibroblast. So I had flasks with fibroblast cultures, and these fibroblast cultures were exposed to radiation like an OPG, lateral surge, chest X-ray, intraoral radiation. 4 or 5 samples to that. The surprising fact was, with multiple exposures, I did find some amount of damage in the fibroblast, but then it was not quantifiable in terms of statistical significance. But the fibroblast did show some changes. But again here, we have a very fantastic technology in our body, wherein there is a gene which does quality check for each of the cell which goes to the next cell. It's called as a P53. So in case you have a damaged cell, it is trying to replicate to go to the next cycle. The P53 does a quality check and rejects that cell cycle, and that cell goes into destruction. Okay. So here I've analyzed how the body works as well as how the damage causes. Now in the experimental setup here is there is no gene which modifies or prevents the fibroblast from going into next cell. Whereas we have a very nice built-in technology which takes care of this small nuances. Like Anand said, radiation, natural radiation exposure is there. Now cell tower, cell phone radiations are there. So we are being abused by a lot of things. At the same time, we are being protected by all these abuses by a beautiful mechanism which is there inside our body. It is just that when is the breaking point going to come? So we should not be responsible for breaking the breaking point. So with that view, I'm bringing in the necessary consciousness to use radiation in terms of diagnostic radiation. But then when you look at the advantages which outweighs the suffering of the patient, it is always worth looking at the problem once more. In dentistry, especially when we have a fracture in the tooth, that's a major issue for us for giving a diagnosis. The patient keeps suffering, so if we outweigh the suffering, it is worth taking a second scan. But then again, the judicial use is what I would recommend. Yes, ma'am.
So, say now, we get exposed to IoT. So, how do we know, like, how much we have got exposed to, and how to find out, individual, how much is the normal rate that we can?
When we come to radiation exposure, we don't feel anything abnormal. Everything is an additional exposure to us. We have monitoring devices. Thermoluminescent devices or PLD batteries is what is the technology available. This is available from third-party sources. You need to subscribe to it. You need to have a 1 year subscription. They will send you a badge. You wear it. And when you send the badge back to them, they will give you a cumulative dose, how much you've been exposed in the 3 months. So like that, they'll give you a dosage for 1 year. Okay. But when you look at the equipment, what we use in the equipment, when you take it intraoral periapical radiation, the cone position, even if it is out of angle, even by half a centimeter, the film does not get exposed. So the chances of you getting exposed to radiation is very minuscule. Again, here the radiation that affects the dentist is the radiation that is emanating from the tube head. So you have a company which has a good lead covering on the head. You don't have to be worried about your exposure. But again, you want to be safer. You stand a distance of 6 feet in a zone of 90 to 135 degrees, which is relatively safe zone where even if there is X-ray in the other radiation zones, in that zone, if you stand, you are not. So you have a long exposure switch, stand about 6 feet.
Risk of being exposed to radiation.
For any repeated exposure, risk is always there. But then the utility of the radiation, the purpose what you are looking, outweighs the number of exposures. For example, when you do a root canal, the process requires multiple exposures. It is not possible to do with one exposure. So the only way how we can prevent the multiple exposure is when you are taking the radiation, where it is technique sensitive in dental intraoral, you master the technique so that the image what you get is not in the undiagnosable portion. If it is diagnostic, that is good enough for us. And now with digital image receptors, the repetitions because of processing error has almost been eliminated. Earlier, if the exposure was slightly more, the image would be very dark. And if you are processing in the liquid, if you are it for even 2-3 seconds, what would have become dark. So readability would have been lost. But with digital receptors, we have eliminated that error completely. thereby reducing the chances for repeated exposure. So multiple exposures and repeated exposures because of the inefficiency of the doctor. So what we are looking at is avoiding the repeated exposures because of the inefficiency of the doctor.
Yeah, too.
Yes, ma'am.
As a register doesn't have a certification, how can we familiarize ourselves with, like when you said, we have seen the different sections and we have seen. Is there any advice you have how we can understand, because many dentists don't, were not able to read and it comes in CDs, and it's always better to be able to show and explain the patient. So any advice on how we can help them practice?
See, most of the present generation dentists are tech savvy. So all you need to do is to orient them to the software here which is bundled with your image. So you give them a hands-on demo of how to use it. The bottlenecks usually are it is given in the CD. Most of the laptops now don't have a CD reader. So you can make alternates, send it by transfer, ask them to download. Once it is there in the system, it is easy for them to use it. And if they are finding it difficult, we can ask them to visit your center and give them a hands-on training on it. Or like you have organized a training, you can organize it.
Good.
No more questions? Yes.
Sir, any specific indications for CBCT only, like without CBCT you cannot go for further diagnosis? This particular condition should be considered, sir.
It's not like that absolute indication. There are many situations where the use of CPCT will give a edge in the diagnostic process. For example, you are a dentist.
My
In a dental perspective of view, the root canal anatomy is very different. Normally, there is a pattern. Most of the teeth have the same pattern. Sometimes there is a variation. So the endodontist when he is doing this procedure, 99% of the times he will be able to identify the variations based on his skill and acumen. Whereas if it is identified earlier, it becomes easy for them to negotiate the anatomy. And sometimes the anatomy is so varied that it is technically not possible for restorative, which should not have been identified by a two-dimensional method. So conventionally, what would have happened was they would have done a two-dimensional imaging, attempted the procedure, which would have failed. Patient would have experienced a lot of pain and discomfort. Then they would have gone in for a CPCT to look for anatomical mechanisms. Now, this happening by chance is a rarity. It is not that every patient has an anomalous scan. So it becomes very difficult to say absolute indication of a CT scan. But it is better than using a medical CT scan in terms of you have the ability to reduce the view and reduce the radiation. Technically, there is no contraindication. If the patient has some issues with standing, cervical spine injuries, where they cannot hold on the standing machine, for them we'll have to make arrangements by sitting. The machine is fixed to the wall, it can go up and down. The wheelchair also can be used. So, as said, there is no alternative to contraindication. In terms for the root canal, he can go in for a root canal. See, the malignancy per se will not be affected by the scan. The scan will not aggravate the problem. Second thing is he might have been undergoing treatment for the malignancy, but that will not contraindicate the use of scan in terms of diagnostic purposes for root canal. It is all over. Yes.
What we make
it and FOV. The radiation is the area that we expected that product exposed to the radiation, or it is entirely radiated and that is cancelled with the
What happens is the focus will come only in that region. The rest of the region, because we have a point source coming out, the machine as a hardware manipulates the dimension. But the path in which it travels, the surrounding area it is minimal, but the field is standardized. It is not that it is cancelled by software later. The amount of radiation that is coming out is only manipulated to collimated to get that radiation.
that those is exposed and that part is like more exposed.
The region which is being the FOV, that is where the entire concentration is there. The rest of the area, because it is a divergent beam, the minimum divergence that comes out is what the patient gets exposed.
See that ball is
Correct.
rotating around. It goes a structure also with it, but when it is generated, the image is only limited like
What you're talking about is the initial scan.
both. Okay. Initially, when we start scanning, all the is moving around the
Right.
that itself is visualized in the software. Yes. Now, all the structures are seen, but when
Only the cylindrical portion. Outside the cylindrical portion, there is some noise, but it is not so big enough for them. Diverging beam, because if it has to reach this point, it has to travel all the way to reach that point. Okay, thank you.
Thank you, Dr. Suhas. It was an excellent talk venue. So, Dr. Suhas gave an analogy that CBCT is like your mobile phones. Actually, we are using only less than 10% of the capabilities of the mobile. The more and more we use the mobile phone, more and more we come to relate. And every periodically, few weeks, the updates are happening, the software of the mobile, and you have to keep updating. That exactly applies to even school music. It's not like learning whole music scan and then taking it. First, take the CBCT. You will get it installed and start using it. The more and more you will spend time, and more you will learn. That's how I also picked up the phone music. I had never heard about the phone music scan before I got installed. It was in one of our reality conferences in the expos. It was kept. So it fascinated me, and without knowing anything about the Golden City, I just got installed. And I started working on it, and that's how I became more and more acquainted with CBCT. And also, Dr. Suhas touched upon so many aspects from the radiologist's view. He used like what are the effects of artifacts, what is called reformatting, what is synthetic panoramic images, color codes, 3D rendering, surface rendering, volume rendering, stochastic effect, optimization, radiation safety, so many things coming from truly radiologist now. So it only tells the clinicians that a lot of things we have to learn from our clinics. Thank you very much for giving an invitation. And I request you to kindly accept a small memento from our side. I request Dr. Srinath, our ENT surgeon, senior ENT surgeon from Anantapur, who has come here to give a small memento from our side. Thank you, Dr. Srinath. So after hearing the whole city from radiologist's view, I'm not a radiologist, I'm a ENT surgeon. So from clinician, how he views the whole CT scan, especially as today's my topic is on role of cone beam CT scan for medial and mastoid anatomy pathology. So first time when I spoke to my colleagues about the cone beam CT scan, I just asked them, how do you feel having a CT scan in your clinic? I got various responses. Somebody said it's a big machine, it needs large space, investment is high, needs many personnel to take a scan, reporting is a big headache. Some said it is time consuming, it's very expensive, some said high radiation is involved. Radiation protocols are too much, we cannot follow those protocols, and some also said that it has got very poor issues. So the cone beam CT scan actually can put all these negative thoughts to the rest. This presentation is appropriate for those who have ENT clinics, those who have standalone ENT hospitals, and those who have ENT daycare centers. Of course, here there are radiologists friends and also the dental friends. It may not be appropriate for them, but it is definitely useful for them. To understand the how the cone beam CT helps the clinician, the busy clinician in his OPD, you should understand these scenarios. Scenario 1, you depend on traditional CT scan. So you refer a patient for a traditional CT scan. Patient leaves the clinic to undergo the CT at an external facility. The waiting time is there several hours or next day for the scan and report. Radiologist interprets the scan and there is a potential for delay. The patient returns to ENT clinic with treatment delay. In this scenario, when I saw the literature, about 23% of the patients fail to show up itself, as per the American Journal of Bronchiology. And 35% who did show up also experienced staples. In another journal of General Internal Medicine, 19% of the patients did not follow through with the recommended testing. And 42% reported barriers to follow through, like car, transportation, scheduling the appointment. What is scenario 2? So if you have cone beam CT in your clinic, patient undergoes CBCT within the clinic, the quick turnaround scan completed within minutes, ENT specialist interprets scan during the lesson. So immediate diagnosis and treatment planning. Patient goes, it only takes 15 seconds for the gantry to rotate. And comes back to your chamber. And the images are there in your laptop. So patient can see images, you can explain to the patient. After thorough clinical examination, you are doing this and you can correlate the clinical findings with the radiological findings. And these all things happen less than 5 minutes time. It's a boon for clinicians who are visiting the OPD. When I saw the literature in European Archives of Otolaryngology, it said, in-clinic cone beam CT improved diagnostic accuracy. That was surprising to me. How can a clinician give more diagnostic accuracy than radiologist? The factor is that the clinician has already seen the patient clinically. Isn't it? He has seen the perforation in the tympanic membrane and then he is seeing the CT scan. So that advantage is there for clinician. That's why there is accuracy, which is 95%. And in clinics, cone beam CT reduced no-show rates and improved the patient retention. So the basic difference between the medical CT and the cone beam CT is, you can imagine the loaf of bread. First you make the slices are made, the medical CT, the slices of bread is there and you actually create a loaf of bread. That is the medical CT. Whereas in the cone beam CT, it is loaf of bread, the volume is there and then you make the slices. So this differentiation you should understand between the cone beam CT and the medical CT. And as Dr. Suhas said, in The medical CT is the fan beam of X-ray which goes and takes multiple slices, probably more than 100 or nearly thousands, depending on the slice thickness. So the slices are weight. And this will take little more time. Whereas in cone beam CT, it takes 50 to 30 seconds for the gantry to run, and it produces a cone of X-ray beam which acquires the whole volume, as Dr. Suhat has clearly clarified. Cone beam CT offers high resolution 3D imaging of intricate anatomical structures. The key features of cone beam CT scan is high spatial resolution of body details. What is the spatial resolution? Spatial resolution is the capacity of the machine to determine the 2 points which are next to each other. How near? If they are very near, still it has to differentiate the 2 points. All this can happen in the low radiation dose, about 1/40th, 40% of the radiation. But I agree. I also, Dr. Anand agrees with me that the present CT scanners give very less radiation compared to the old CT scan machine. But still, compared to the latest CT scanner, cone beam CT scan offers less radiation. And quick acquisition time is the one thing which is important for a very busy clinical practitioner in the OPD. And it is widely used in otology for mid-layer and master because mid-layer and master contains air, and air is a very good contrast material, natural contrast. And we have to understand certain terminologies. What is this tomography? It's a method of producing three-dimensional images of internal structures. The device is called the tomograph, and the image is called the tomograph. What are these Hounsfield units? This is quantitative measurement of the radiolucency of different materials in the CT scan. So the Hounsfield unit of air is -1000, whereas for water it is 0. For cortical bone it is 1000, and cancellous bone it is 400, and for metallic structures it may be from 2000 to 3000. So depending on the Hounsfield units, one can actually measure the Hounsfield units with the cone beam CT, and can, even though the CT doesn't give the good density resolution, it cannot tell the soft tissue resolution is very less. Based on the Hounsfield units, one can fairly get an idea of what he is looking at, whether he is looking at the thick pulse, or whether he is looking at the glue in the middle ear, or any fibrinous material in the middle ear, all that you can get the idea. So DICOM format is the digital imaging and communications in medical medicine. We can call this as a software which can where the data can be, the digital data can be transferred between various diagnostic imaging equipment. Pixel is the smallest single component of an image in a 2-dimensional grid, whereas voxel is a 3-dimensional. The very good image was put by Dr. Swas in his So this is the diagram of the Hounsfield scale. Hounsfield scale HU is called. You can see on the left it is air. For air it is 1000. For fat it is -100. Water is 0. That is taken as standard, and everything is compared with water. And soft tissue is 30 to 45. And then at the end you can see the particle bone 1000, whereas the cancellous bone, which is seen in mastoid, can be up to 300 to 80. Field of view is the area of interest to be covered during the scanning procedure. The small field of view, also referred as the limited or focused fields of view. The scan height and width can be less than 5 centimeters. In medium field of view, the scan height can be between 5 and 15. In large field of view, the scan area is from 15 to 18. And in fact, earlier CBCT scans which were available with our dental friends had FOV, less FOV, that is probably small field of view, and slowly it went into medium field of view. The present scanners has large field of view. It is the large field of view scanners which came, and that has become interesting. Now from skull base to the mandible, it can be taken, and that is the reason it is now being popularized around the world. And there are basically 3 phases. It is just what happens is the acquisition phase acquisition of the images happen within a few seconds, and then the reconstruction phase. Here, the images are formed and created a database, and this is converted into the orthogonal images, and we can publish for viewing. All this will happen quickly. And comparison between the CT and the CBCT. So CT uses high output rotating anode X-ray tube, and high power is necessary. You can't install a CT machine with the existing power in the hospital. So you may have to apply it for the storm to get more power. Whereas cone beam CT scan is it utilizes low power and the fluoroscopy tubes that provide continuous imaging during scan. The regular medical fluoroscopy tubes are enough, and the power consumption is less. And probably we can call this literally we can call this as a plug and play equipment. So installation can happen within few hours and with no extra power. So this is a great advantage for the clinician. In the existing facility, if you need a space, you can install the machines. And fan-shaped X-ray beam is used in CT scan, whereas cone-shaped CT X-ray beam is used in CT. We produce a single slice images per scan, that is in medical CT, whereas in cone beam CT it produces complete volume image in a single rotation. The longer scan time, because there the more detailed scan is happening in medical CT, but in cone beam CT, it's faster, it takes 7 to 30 seconds, depending on the rotation. So high radiation dose is necessary, sometimes 1200, sometimes it goes up to 3300 microsieverts, and less radiation dose around 36 microsieverts. So if you divide 3300 by 36 microsieverts, as per this, it is nearly 100th of the radiation. But the standard teaching is that the CBCT produces uses only 40% of the radiation. The cost, of course, the medical CT is high. When compared, this is cone beam CT, the cost is cost efficient, and patients with claustrophobia, it may be detected in medical CT, and CBCT eliminates claustrophobia, it enhances comfort for the patients. Coming to the applications in mid-ear imaging, CBCT produces clear visualization of ossicles. Malleus, incus, and stapes can be clearly seen because it is surrounded by air. So it helps in diagnosing ossicular chain disruptions after trauma or even otosclerosis. And it also supports the surgical planning for procedures like stapedectomy or tympanotomy. And applications in mastoid imaging, again, mastoid contains air, and so detailed imaging of the mastoid air cells can be and the bony structures can be seen, and useful in identifying chronic mastoiditis, cholesteatoma, and also it is helps in critical planning for mastoidectomy, whether we have to do an open cavity or whether a closed cavity, like that a surgeon can get details going. So this has been already emphasized again and again, the advantages of CBCT or high resolution imaging, especially for bone anatomy. Low dose radiation compared to conventional CT, quick and cost effective, and enhanced precision for surgical planning. Of course, there are a lot of limitations with the cone beam CT scan. So I can say the cone beam CT, 80% of our ENT surgical planning diagnosis, 80% of the cases it is enough. But there are 20% of the cases which need a regular conventional high resolution scans. We have to take help of friends for those things, and that is because CBCT produces limited soft tissue examination. It cannot differentiate if two soft tissues are there, muscle and there is fat. It cannot differentiate from them unless you measure the outfield units, and you may get some idea about that, but still it is not accurate. And smaller field of view than the traditional CT. Traditional CT gantry in the helical gantry helical CT can go from head to toe, whereas here you are fixed to a certain structure, like depending on the FOV of your machine. And cone beam CT also requires interpretation by the expert. Even though it is the clarity is so much that the clinician with his clinical knowledge, with clinical radiological coordination he can do, But if you depend only on the scan to tell the diagnosis, then again, we have to depend on our requirements. And it is less effective for soft tissue pathology. Here I run through some of the slides to show that how the CBCT helps in diagnosis. So here on your left, you can see the mastoid hair cells. You can see the hazy mastoid hair cells, and also this patient, this image also shows the haziness of the posterior ethmoidal hair cells. And on your right, you can see the hazy mastoid hair cells, which is suggestive of acute photomastoid. You can with the CBCT can see the sinus plate position. If there are any erosions, you can before surgery you can know if there is an erosion. And in coalescent mastoiditis, you can see the mastoid hair cells are coalesced. That is, the partitions in the mastoid hair cells are eroded by the disease. So you can, if there is soft tissue swelling in the extraordinary canal, as you see the left scan, you can see, and this patient had malignant otitis external. And you can also see on the right scan the granulations which are eroding the extraordinary canal. And you can also diagnose the attic cholesteatoma. Okay, you can see the sputum is eroded here, and the soft tissue shadow is there in the attic. And here on the right side scan, you can see the erosion of the sinus plate. Probably the cholesteatoma is eroded the sinus. It is also helpful in diagnosing the fracture of the temporal bones. You can see the longitudinal fracture of the temporal bone, and you can also see the ossicles if it is eroded or not. And these images in the software, actually these are printed films, but normally we see the raw images. We hardly this printouts we give only for the patients to carry, but we report everything, diagnose everything based on the raw images. We run the raw images, which I will run now after this talk. There, everything you can see, you can magnify, and you can see the ossicular change. Independently, you can see the magnets in different stages. But in a film, you cannot magnify. And in coronal views also, you can see the CT, you can see the fracture line running in the pitcher's bone. And this is a transverse fracture which is running the pitcher's bone, and you can see the displacement of the pitcher's elements there. And on the right also, it's the fracture of the pitcher's bone, and ossicular chain is intact. And you can see the pitcher's cholesteatoma erosion of the pitcher's apex. And probably this is the patient needs subtopic pittorectomy. Like that, you can start seeing the scan, you can take the decisions. Such decisions. And you can see the diameter of the internal auditory meatus. And you can see on one side it is 7 mm, other side 6.8. Clinically, the patient is having unilateral sensitive reading glass. Then it probably is having acoustic emissions. Then, of course, you have to send this patient for the MRI scanning and so on. But what I want to send the message is in the BC OPT, you can come to the quick conclusions. So in here you can see in the case of acoustic neuroma, you can see asymmetry of the interval. On one side, on the left side, the interval. In otosclerosis, you agree with me, the colleagues, otosclerosis is a disease which is conducting hearing loss. That is because of the fixation of the smallest bone of the body, that is stapes. So that is called otosclerosis. And normally this is a clinical diagnosis. You see an intact recurrent membrane, patient is having conductive hearing loss based on the clinical test, and the patient is having a family history of conductive hearing loss. You know that you are dealing with otosclerosis. No other investigation is necessary other than audiometry. But again, nowadays the protocol say that you have to go for a CT scan for the diagnosis. The CT scan can show the bone around the oval window, the Hounsfield image will be lesser than the top. So if that is there, then you know you are dealing with otosclerosis. So the clinic, based on our clinical knowledge and audiogram findings, if you get the findings from the CBCT, it is useful for you when you do intraocular, especially in the unilateral otosclerosis, and when patient is not having family, still you are doubtful that whether you are dealing with a case of otosclerosis or tangential fixation of tape is problem. CBCT also helps. And the ossicular chain erosions, you can clearly see the disruption of the ossicular chain. So what the CBCT versus the medical scan, CT scan for diagnostic assessment of conjunctive hearing loss, the Journal of International Advanced Otology says that in this research, 5 human cadaver heads were scanned using both the regular CT and the cone beam CT to evaluate 16 anatomical landmarks related to conjunctive hearing loss. The results showed that cone beam CT provided superior image quality with significantly lower radiation dose compared to the medical CT, suggesting cone beam CT as a promising alternative for conjunctive hearing loss. In Acto Radiologica, which in this study compared with CPCT and traditional CT imaging the middle ear, the findings demonstrated that CPCT is at least as accurate as the medical CT in revealing clinically and surgically important middle ear structures, highlighting its potential as a diagnostic tool. So now I want to show the raw images of how the normal middle ear looks and one or two cases of pathological middle ear enlargement. So patient, once you refer the patient to the CBCT, which is just to keep it, just one floor over clinic, he goes there, it takes 20 seconds to acquire and he comes back to your chamber and these images are in the laptop. Once these images are there in the laptop, then you can actually in front of the patient, you can see these images. So let us see the first so of the coronal and you already have the, you already know you have seen the patient, you have taken the history, you have done the clinical examination, you have come to the clinical diagnosis, then you have sent for the CBCT. So almost 80% you know what is happening. So then it becomes easy for you to scan. Just the scans you can just scroll the scan, the area of interest. You can see here. You can see even though this scan was done for the middle and mastoid, you can also see the other structures. So here you can see that maxillary sinus is the fluid level. You can see the turbinate hypertrophy. You can see the bone spur in the nasal septum. All these things. So you can run from one end to another in front of the patient, and you can quickly come to the diagnosis. Now the area of interest was the middle ear. So I can also go to the middle ear, and you can with the pointer you can keep showing the patient what all you are seeing by scrolling like this in the coronal views. And now you can see the sphenoid channels, which is clear. Now come the area. You can also see the TMJ, all these things you can see in pertaining to that particular case. Now you can see the middle ear shadow which is appearing. Okay, you can run through like that, and you can see the tympanic membrane which is intact. Okay, tympanic membrane which is intact, and you can see behind the malleus, and you can go like that, run like that, and see the continuity of the ossicular chain. You can see the continuity of the ossicular chain by doing that, and you can see the cochlea. Clearly, the cochlea you can see, and you can also by go behind and you can see the mastoid hair cells, whether they are aerated or diploid or the sclerons or the coalescent or in the fluid level. So you will know the thing. You can also find the level of the sinus plate and whether the tubular bulb is higher or and also tegment plate to know whether the low lying dura or you. So you get 80%, if not 100%, 80% of the information beforehand. So in this case, it was a normal. It was scan to show you that how the normal mastoid and how the normal wiggler looks. So ossicular chain, the ice cream cone appearance. This is ice cream cone appearance, which is normal. Okay. So because the cochlea is seen clearly if you have any implant, post-implant, cochlear implant. If you run the scan, you can see the implant electrode very clear. So that was the normal miliar and mastoid. I'll show one more case. So the latest case, I just want to share this. This patient, on the left, sorry, it is not a clinical photograph. This patient had CA buccal mucosa and CA buccal mucosa, and he underwent the outside facility. He underwent the commando operation, and he present commando operation about 3 months back for the carcinoma of the buccal mucosa, and then he presented to us, and he underwent radiation therapy also. He presented to us with the conductive hearing loss. Okay. Conductive hearing loss. Then we took the cone CT scan. When we examined the tympanum clinically, the eardrum was dull. It was looking something like a glue ear. So the clinical diagnosis was glue ear. Then we sent him radiation-induced glue ear. That was our initial thought. Then we went for the scan, cone CT scan, and I will show you the axial scans here. And what we see here now, you can see on the right side of the patient, the mastoid ears are clear in comparison to the left side. The mastoid is hazy, but the critical lesions in the mastoid was well maintained. That shows that there was no erosion. Still, it was to us, it was looking like a glue ear. So then there was no bony erosions. There was no granulations in the extra-aortic canal. So our diagnosis of glue ear was made, and that was the cause of conductive loss. So we saw in all the 3 planes we saw that. You can see on the left side auricular chain, right side auricular chain is clearly seen. Then we saw in we critically studied all the views. And this is corona scans. So what surprised, what was, we thought it is, so there was a thick fluid, so we measured the Hounsfield units to know whether it's glue or something else. If the conductive loss was severe. So we measured the glue, we measured here, it was like, it was quite thick. It was something ranging from 400 to 500 Hounsfield units. Sometimes it was also 600 to 700. Compared to this side, you can see the air produces, it should be minus 414, minus 393 like that. So it was thicker than the glue. So to me it appeared, and in fact discussed with the Shreyas, this doesn't appear like glue. It's a radiation induced, probably some thick material, something which is going into the fibrosis, left like that, thicker than glue. That was our diagnosis after seeing the stone beating. So instead of deciding only to put a grommet in that case, we decided that we have to do a tympanotomy and push it. Such tympanotomy and push it, because it is not just doing. So as we expected, when we opened the post-oral approach, we elevated the tympanic membrane, and we can see it is running in speed 3x, 4x speed. So you can see here we are skeletonizing the malleus, and we are elevating the tympanic membrane, and we see that there's a thick fibrinous material, not the glue. It's a fibrinous material which was occupying the material. So if we had put the glue here, it would have been a wrong decision. So along with our history and the clinical findings, CBCT helped in surgical planning. That's what I wanted to send a message through this case. This was operated only yesterday. Patient presented to us 3 days back, and yesterday we operated this patient. And we can see that it's a thick glue. And yesterday evening patient was discharged. So thick glue is there. You can see that, and that was the cause for the conductivity. You can see the malleus which is intact. And the whole midline was covered with flutinous material. And even the scan showed that the similar shadow was there in the mash pad. So we decided to open the mash pad. And mash pad after was also filled with thick flutinous material. Then it was extended to the attic. We also did atticotomy and released the flutinous material from the incus and the malleus. Then we achieved the patency. And ossicular chain was made. And this is the post-op photograph. In fact, I requested the patient to send the photograph today morning. And they sent these photographs today morning. Because he was operated elsewhere. The primary surgery, that is command operation, was done elsewhere. So now, CBCT, where we stand. There are a lot of innovations happening in CBCT technology. We are already late if we have not started CBCT. That's what I mean. So now, artificial intelligence integration is happening, and this is doing automated diagnosis. And portable CBCT systems for point of care imaging this. So patient when they come now, immediately they want everything to happen. That is our experience. As a visit practitioner, that is my experience. You say you are having sugar, immediately they want blood sugar levels immediately down. That is called point of care. So they're expecting even the CT scan and also to happen. And one good thing in other countries, even the cone scans, cone vans are there, where the mobile cone beam CT scan vans are there. So that was something interesting. I told my people whether such a thing is available in India. They said AERB has not given permission for those things, and probably it will happen. So once that happens, it is the talk of the town. Every man, every person will know. Today, every patient is a Googler, unless told otherwise. He Googles and comes to you. He knows everything about that. When you tell Quantum City, he already knows half of the things that the Quantum City is like. So now, image-guided surgery is happening. The images, and one good thing about the Quantum City is these images are compatible with our image guidance. And real-time surgical guidance also is happening now. Even for those things, Quantum City can help you. And coming to the AERB regulation, the Atomic Energy Regulation 4. So here it says that, of course, for installation, you need a license from AERB. Whereas for personal monitoring, whether the persons taking the CT scan should wear the badges, PLD badges, to calculate the total dose. So it is only recommended. Even AERB considers CBCT as a dental machine. That's why they are telling that it is it is only recommended, not mandatory to wear the glasses. That is because of the low radiation, low radiation. So this is the present AERB regulations. And so to conclude, I can say CBCT is a game changer. It is invaluable for mid-layer and master imaging. It provides precise anatomical landmarks details with lower radiation dose. It facilitates accurate diagnosis, surgical planning, and thank you. So you can. The house is open for discussion. After this, we will proceed for coffee break. Yeah. Yeah. Tell me. Yeah. Yeah. You understood very well. Thank you very much. Yeah. So it covers 80% of our clinical needs, not 100%, 80%. How much weight required? Probably you came the lift, isn't it? Twice the lift size. 8 by 8 is enough. 8 by 8 is more than enough. And after the workshop, you can actually go and see our CBCT machine, and you can have the first-hand experience of the space. Just one wall. In one wall, for dental surgeons, one wall is enough. For EAT scan, which has a larger FOV, 8 by 8 centimeters. Yeah. If you are building the hospital, the 9-inch wall, you can request your contractor to put 9-inch wall. That's enough. Otherwise, in the existing facility, you put the lead sheets. It's very readily available. They will install within 1 day. And the doors also, the existing doors, they will just fix the lead and small opening in the door with a lead glass. Yeah, it's a room, and the ideal is suited for if a couple is ESD and wife is 10%. Ideally suited for it. Because both of you will use it.
So we should just wait for the demand to come from that side.
It has actually happened. That's why you are attended. Your wife was very particular, he has to attend. That's why you have come. He is Dr. Chinnan, he is a rhinoplasty surgeon. His wife is, I think she has come here. Will not have come. Okay. So for your information, the whole proceedings are happening online also. From the city, it depends on FOB. I think complete people are here with you. Anand is there next to you. He will tell you. Cost per scan. Cost per scan. Okay. Cost per scan. In a place like Bangalore, 3,500 to 4,000. They are for an ENT scan. They are offering. See, what I have seen is when patient comes to a busy OPD, they want point of care. So when I say we need scan, the next question is whether it will be done here. When I say yes, then they will tell whether we will get the report now. When I say yes, then they immediately they will Google Pay and do it. But once they leave your chamber, then as I showed you, literature says that about 25% of people will not take the they will not go back, they will not come back, they will change and all. So that is the one thing which basic clinicians can do.
Going by your patient that you showed, had he had to go out and come back, then another minimum 2 days he has to go, then come back to the films, then you see.
Yeah.
But he came 1 day before, then you saw next day you were operated.
Yes.
That's what he told.
Yes.
If I remember that was within 2 or 3
Within
days.
2 3 days.
Surgery
This particular patient within 2 because they wanted a good day and all that. Otherwise, if patients are ready, we have the OT free. We will do next day itself.
At the other thing, economic price also looking at it. Why do we prefer air travel over a train or anything? It's about saving 1 day because 1 day is worth a few thousand rupees for a lot of people.
Yes. Yeah. And a place like Bangalore, they cannot go back and come again for the same thing. If it happens at the same time, then it is quick problem. But this can happen not 100% of the time. You cannot depend on CBCT. Anand is here, this lecture is there when the regular CT is necessary, when other than CT, MRIs are necessary. We should always respect higher investigations. And expert advice is needed. Here your advantage, you are having advantage that you have already seen the patient, you know the tympanic membrane perforation is there, and then you are seeing the CT scan. Okay, CT scan. So there is an advantage. But for radiology friends are seeing only the scan and they're telling that they need expert advice. So there's a lot of difference between. And when my patient asks for the reports, I say the expert report you want, I will arrange the expert report from the radiologist. But I will give them a clinical radiological correlation report. And I put a disclaimer clearly telling that this is not radiologist expert view. This is from the clinician angle for him to give an information about the surgical plan. I clearly mentioned and tell this point to the patient. Okay. Yeah. Is it useful for head and neck lesions or no? Yeah, he is our international delegate. He is Dr. Bhaiya. He is from Nepal. He is a professor from Nepal. Thank you. And thanks for coming. No, no. It is having limited use because it doesn't have solution as Dr. Suhas is already told you. But you get a little bit idea. But the MRI is the image. But rhinological? Yes. In nose and paranasal sinuses, which is the next lecture by Dr. Shreyas, so it is again surrounded by air. So it is an excellent investigation. To what level? All the sinuses, nasal cavities, all the sinuses you can see with the simplicity. The
Data-
next
data-
lecture is on that.
Yeah.
Your questions will be answered.
Good, excellent. Very much.
Thank you very much. We'll go for coffee and come back in 15 minutes.
No problem.
Detect multiple display. One selected a file. Oh, okay. Oh, very good. Okay. Yeah. Yes. Which is there. Okay, I will press it. Okay, man. Super. I disconnect. Yes. Okay. Thank you, man.
also we can. So it's important small amount of cognition addition to the posterior lobe. So you have to use your magnetic instinct at the same time and then do this. So this is like double task. And as the progress improves versus we have more difficulties. That's also so scientists will be tell what is the simple case. We have to understand. The other one you need to do for a scientist or for a doctor. So that then the other product is this. This is the again world's most simplest Rhinology for one. Whatever I did, so clinical zero location, national test, advanced advanced advanced. So I just show you what are the this is the big one.
Hello, delegates, please take your seats. If you are not, if you are still not have your coffee, just collect the coffee cup and please come inside. And you know, when once you are with Dr. Srinivas, you know, he attracts everybody so much. Okay, attracts, distracts, everything. Thank you. He's a hero, you see. Srinivas, you also have coffee and come, no? Dr. Srinivas Doresala, please collect your coffee and please come with the cup. Srinivas, you also have coffee and come. Collect the coffee cup.
Good. Good.
Audio very low. It's good, but like a first line.
Hello, welcome back. So the next topic is by Dr. Shreyas Pradeep. He's going to speak on cone beam CT scan of nose and parallel sinuses. So I'm happy to introduce Dr. Shreyas Pradeep because I know him since birth. He's my son. So he did his primary education, high school, everything from Jain Vidyalaya, Bangalore. Then he went to JJ Medical College, Davangere. There is MD, MBBS, and MD he did from Otolaryngology College. After that, he went for training from microtia surgical training under Dr. Nagata in Tokyo, Japan. So after his short fellowship program, he again went to Dr. Peter Burman to Australia for skull-based surgery. After that, I got him and held him here, and he is now taking care of my clinic in South Africa. We are running clinic. He took over from me, and I stayed here. And both of us operating in Laryngology. So he has been an immense strength for me for all my academic programs. He's always there helping me and sharing with me. And he is there with me today. And I welcome Dr. Shreyas to take up with me. So, thank you for the wonderful introduction. So I'm Dr. Shreyas. I'm working here as a consultant, ENT surgeon, and it's my honor to be presenting in front of all of you. And as ENT surgeons, this is one of our most favorite topics, I would say, because paranasal sinuses today, everybody is actually venturing into surgeries of the paranasal sinuses. So before we begin the topic per se, I want to discuss about this particular X-ray. So I finished my post-graduation in 2015, and even back then, this was one of the most frequently asked evaluation for paranasal sinuses. So this is the Waters view. So we could analyze the frontal sinuses, maxillary sinus, little bit of left point, but we used to discuss whether we have to keep the mouth open or closed, what are the advantages of keeping the mouth open, how we analyze this data. But the kind of surgeries we are doing today and the kind of procedures we are doing over the sinuses, the amount of information we gather from this particular film, and to be able to decide how we go about, especially with the sinus anatomy being so varied in every person, the amount of information that is gave was grossly inadequate. So we required something much better than this. Luckily, we are in an era where we have computer tomography. So a computer tomography, basically, tomo means slice and graphy is image. So let's take an analogy of slicing an apple. So it is basically an apple which is sliced. These slices are then put together to create the entire structure. So this is how, or this is the working principle of what the CT scan does. When this is done by a computer, it's called a computer tomography. So just to understand, I know Dr. Suhas is very nicely explained to us how the CT scan works. So we basically have an X-ray source, and exactly about 180 degrees to that we have a detector. So when the X-ray and the detector move together, so when an X-ray source is placed over the area you want to scan, so basically in this we scan the parameter sinus, patient is lying here, the X-ray source is below, the detector is below, this moves around the patient. And when it moves, it produces fan-shaped beam like this, and every time it moves around, it takes one slice. So by moving this motorized cable under it, it moves multiple times and we're able to create multiple slices. Through this, you actually reconstruct the entire image. The reconstructed image looks like this, where you take a series of images. What is represented in yellow here is actually the position where the slice has been taken. So multiple slices have been taken here, and one is placed next to each other, and you're able to understand what exactly is happening inside the sinus. But now technology is further advanced. We are able to create 3D reconstructions of the images that are acquired from this. Okay. So the CBCT or the CT scan of the Northern Sciences is a modality of choice today for the evaluation of the parameters of sciences. So we can acquire images in axial, coronal, sagittal cuts, and today we are able to do 3D reconstructions using these images acquired. So it is helpful in both preoperative and postoperative management. So to address the elephant in the room, what is CBCT? What is cone beam CT scan then? So this, as we understood, we have a patient. Let us just see what is the difference between the regular CT and the cone beam CT scan. The X-ray source produces a fan-shaped beam, and we have a detector here. But in the cone beam CT scan, so the X-ray source produces a cone-shaped beam, and the detector here, instead of a linear detector, we have a plate-like detector, which is much wider. So when the cone is produced by this X-ray source, the organ of interest is placed in between, and in a regular CT scan, this goes multiple times to take the scan of an organ of interest. The cone beam initially itself you basically assign which is the organ to be scanned, and this goes only one rotation, and with that one rotation it acquires the entire molecule. So this is the basic difference between the conventional or the fan beam CT scan is called and the cone beam CT scan. So cone beam CT scan can create slices as thin as 0.1 to 5 millimeters. So always our interest is how small the slices are, and so that we don't miss the smallest of the lesion. When we take a conventional CT scan, basically multiple slices are taken, and then you analyze the full image. In here, you acquire the entire volume and you then create the slice. That's one difference. And CBCT is a promising modality, especially because it is a big outpatient modality of medical. It has a very low dose ratio. It has an acceptable measure artifact interference, and it gives a comparable diagnostic radiological accuracy for us. So moving on. So the moment you imagine a CT scan, you always, at least for me, I've always imagined a big machine occupying an entire room, and it is having a lot of room next to that. There are radiologists or technicians sitting there acquiring images. Needs a lot of manpower. But in contrast to that, a CBCT is actually very, very small. It fits into a room, I think, as small as I think Mr. Anand was right for 6 into 6 feet or 8 to 8 feet is what they recommend. So it basically has a very small footprint. So within a small existing room, if you have an additional room, you are able to put in a CBCT machine. And so basically, CBCT produces very high resolution images. Low dose of radiation. We already discussed about acquisition time. The equipment is quite compact. It is cost effective. both for the center because the power required everything is much lesser. It is a versatile equipment. Dentists, radiologists now scope is expanding into the orthopedic field as well, and it is patient friendly. The reason why I say this is because patients are claustrophobic. When people have to enter a gantry and get the imaging done, it can be slight daunting for some patients who are claustrophobic, and the seeing open is very nice and it feels good for the patient. And it just goes around one location, so maximum acquisition time may be about 15 seconds already. So let us further understand the dynamics of the CBCT. What are the pros and cons of it using certain case studies. This image, this is the software which the My system will produce for you, and okay. So basically here, I know there are many radiologists sitting here. I would not be talking about in a radiologist perspective, but in a surgeon's perspective, I will be making my presentation. We had a young 14-year-old patient who presented to us with a suspected fracture of the nasal bone following a self-inflicted trauma. So ideally, what we want to know as clinicians is there a displacement of this particular fracture? In what orientation is the displacement happening? So one of the ideal views for this is the axial views. So what we do is we take the axial view. We see that I see almost two fracture lines in this particular patient, one on the right and the left, and I also see a fracture line here. So we also see the dorsum of the nose that is actually shifted slightly to the left side of the patient. I was thinking we will go in a little more detail only on this particular scan, and there are a few more case studies to be discussed, but we will not be going too much into detail. I just want you to appreciate all the details the CBCT is able to provide to us, and all the radiological analysis which we used to do in a conventional CT scan is still possible with the CBCT scan. So we are going to go from the front. This is not going to be the surgeon's perspective or the surgical perspective. We always operate in the coronal plane. That's why we have chosen the coronal plane to discuss here. So this is the front of the nose. We can go from the tip of the nose, especially when you're integrating navigation images. We want the tip of the nose to be scanned, and we always ask our technician to scan the tip of the nose so that if suppose we need to use image guidance during the surgery, it is possible to do. So we're going from the very front of the nose, we're going backwards, we're starting to see the septum up here, it's fairly central here, and we're going to go a little more. Of course, we do appreciate the small fracture lines there, but it is much better appreciated that the coronal and the sagittal has. So we start to see the frontal bone to appear here, and as we go, we are starting to see the frontal sinus. You can see a very good mineralization of frontal sinus in the frontal septum, which is separating the frontal sinus here. So one of the first cells to appear is actually the ethmoidal, the first ethmoidal cell here. So this is called the agarine cell, which is actually mineralization into the frontal process of the maxilla. I wanted us to see here that this is the frontal sinuses here. We see a thick piece of bone underneath. This thick piece of bone is actually the frontal beak. As we go a little more posteriorly, this starts to disappear there. So what we see here, when this bone has disappeared, is not the frontal sinus but the frontal rhexis. You can correlate this particular feature. Let me see. So we go to the right side here, and we come to the very front. Okay, I will place my cursor here in the sagittal guts. what you are seeing is actually the frontal beak area, and frontal sinus is present immediately above the frontal beak area. But as we go back, you can see the cursor, it has moved back. This is actually the frontal beak area. And you actually move back and you're seeing a lot of cells which are occupying the frontal basis and not the frontal basis. As surgeons, we want to know where this frontal sinus is draining. It's having a medial drainage pathway or a lateral drainage pathway, because radiologists are very good. They may give you the pathology, but for the person who's going and operating, as a surgeon, you want to know which way you want to actually go in this particular patient to access your frontal. So you can also see the nasal lacrimal duct coming into it. So this is your orbit. You see the nasal lacrimal duct. This is on the right side and left side, both the area. If you can follow it down, it is opening into the inferior meatus here. The turbinate on both the sides appear quite prominent, and we're starting to see the middle turbinate, which is appearing in both the right and the left side. And the orientation middle turbinate is good, but there seems to be a concha bullosa or a bulletized middle turbinate, which is a bullous site in this case, and this is a normal middle turbinate. We see a lot of cells which is occupying the frontal basis area and narrowing the frontal basis area. So one of the key things we also want to see is this particular structure. So this is the uncinate process. So let us follow the uncinate process upwards. So if you see the uncinate process, it is going here. Let us follow a little more. We are starting to see this uncinate process is taking a turn medially. So let us see that it is taking a turn medially and attaching to the orbit. So it is laterally and attaching to the orbit. So if the uncinate process attaches laterally, then the drainage pathway is going to be a medial drainage pathway. So that is what I wanted to highlight. You can actually observe the middle turbinate attaching to the cribriform plate. One key thing here, you can see a big mineralization running all across here. This you may get confused with the the frontal sinus, but actually that's a supraorbital cell. So this is a mineralization above the orbit, and this is not your frontal sinus. Your frontal sinus has ended where this beak was present. So immediately after this, all these cells, what you see is actually ethmoidal mineralization. So let's move back a little more. Yes, there is a slight deviation of the nasal septum to the left side. We're going back a little more. Now let us focus on the maxillary sinuses here. So we want to see what is the status of the osteometric unit, or is it blocked, or is it draining, and does it have a good patency? I see that there is a slight thickening in and around the osteometric unit, but this is fairly okay. You can analyze the left side as well while doing so. One other thing what we are interested here is looking at the level of the skull base also. If you notice here in the center, this is the skull base at the superior most aspect, but in the center, the skull base is far lower down in comparison to this. This is something we want to know as an ENT surgeon who is taking up their case for surgery. So you don't want to be going more medially in this particular patient. This can actually injure, and the skull base is the thinnest around the fovea epididys and can cause CSFT. So it becomes very important for us to know how low the skull base is. That's how ENT has classified the location of the skull base. So let's move a little more posteriorly. You start to see that the skull base is becoming more and more flatter here. So, and the number of ethmoidal cells are reducing in number. So this is suggested that these are posterior ethmoidal cells, and the posterior ethmoidal cells will slowly transition into the sphenoid sinus here. So you can see an unequal division of the sphenoid, right being very large and left being quite small. And that is something you need to know. And how to differentiate? Yes, you can see this is the posterior ethmoidal cell. You can see it is moving from derion to derion. But as we go a little more posteriorly, you start to see that
these bones are disappearing. This is actually the greater wing of sphenoid. So this is actually the sphenoid bone, and that was the condyle bone. So this is located inside the sphenoid bone. This is the anterior sphenoid process. You see the projection of the optic nerve, and you have the internal carotid prominences there. You are able to see the cella here, and so basically, I thought all the things which you would appreciate in a normal CT scan, we are able to do in a CBCT as well. This is what I wanted us to go through. Okay. So we go to the next case. So this is one of the typical pictures which you would normally see. We will only go through the highlights of this particular case. So patient presented to us with bilateral nasal obstruction, severe history of allergy was there, history of one surgery earlier was also done. So when we went through the scan, when we did the clinical examination, there was bilateral ethmoid polyposis, completely, blocking the nasal cavity. There was absolutely no place for him to breathe. So when we went through the scans, yes, there was probably a septal procedure which was done, which is what we understood. There was complete opacification of the frontal sinuses, complete opacification of the axillary sinuses on both the sides. The left side had some air pockets, but right side was completely opacified. All the ethmoid group of cells were completely, filled up with polyps. We could in fact see the polyps coming down to the floor of the lungs. So there was absolutely, patient had no space for breathing. It was only to the left nasal passage that he was able to breathe a little bit. So our important things to see, especially when we are going in a repeat surgery or a revision surgery, we want to see what is the location of the anterior ethmoid arteries. So you can see the anterior ethmoid arteries are exiting. You can see the exit from here and going towards the skull base, and here there is symmetrization of the anterior ethmoid arteries. So this is called the Galilean circle, and you can see the anterior ethmoid artery is symmetrized at the top there. So the ethmoid artery is actually going from mesentery here. This is something we want to know. We want to know the status of the lamina pathways here. This is the thinnest portion of the bone which is separating the orbit from the sinuses for us. So we want to know the status. We want to know if this has been breached in the previous surgery. We want to know the status of the skull base here. Many times we are clearing disease up all the way up to here. We want to know what is the status. We want to know, of course, what is the free status. So we want to know which are the sinuses and what are the frontal, maxillary, ethmoid. They're all full, but the sphenoid sinuses seem to be fairly good. So this patient was planned for 2 hours sex, and patient is doing quite well. So let's take another example. This patient presented to us with swelling and pain around the right neck, upper portion of the neck. He had jugulogastric lymphadenopathy. On examination further, we actually noticed that he had tenderness in the tonsillar area. On taking, on digital examination, we found that his thyroid process was quite elongated, and we were suspecting Meniere's syndrome in this particular patient. We took the scan. Basically the idea of this presentation was the possibilities CBCT is giving us in analyzing so many things for the ENT perspective. We saw there was some soft tissue densities in the maxillary sinus, but more interested I was in the we're going back in this thyroid process. So this is the thyroid process. So what I want us to only focus on this particular structure. We just keep following it. We keep following it. You see the thyroid process is running all the way, and this is the neck, and this is the tonsil. So it is coming all the way up till here. This is quite a long thyroid process which I had observed in any patient. So what we did, just to analyze, it's the right side. I'm placing my cursor here. Let's run through the scan. And I'll orient the axis along this. So, we do a sagittal cut. That's your thyroid process starting from all the way from the base till here. So we can also take measurements. So we took the measurement. It comes to about 57 millimeters, which is quite long. It's almost 5.7 centimeters. So the normal anywhere a patient becomes symptomatic of 3 or 4 centimeters to an extremely long thyroid process. So we are really able to tell the patient that yes, we have a very long thyroid process, and this is the reason for the very clean surrounding, throat. And in fact, this patient had a quite an elongated thyroid process on the opposite side as well. So just to continue the discussion. So the more you play around with these images, you will figure out that there are so many possibilities this will give us. So this is a 3D reconstruction. Let us put it into our glossy mode. There are different options which we give. I'm sorry you can't read what is here, but there are different modes which are available here. In the evening, you can actually do a hands-on session where you can handle soft tissue and the bone, and you can actually check here. So let's go for only a bone window here. We can remove the only a volume is seen. We remove the bony tissue from the front. Okay, now we are able to see the thyroid much better in the 3D reconstruction. So even here, we are able to take the measurements of the thyroid and to make the patient understand, because our understanding may slightly be different. The patient will be able to analyze and it sees the beliefs. So we are able to convince the patient even better to these images. So we on to the next example. So I particularly chose this particular scan because this gave us a challenging experience. So basically, when I first looked at the scan, it was quite straightforward. Patient presented to us, it was a 47-year-old lady who presented to us with a nasal obstruction. Initially, she had a nasal obstruction. She is my old patient. I told her that you have deviated nasal septum, that's the reason you're not able to breathe. And of course, 2 years later, she presented again. She says, now both my nostrils are blocked. So we went ahead with the scan. Even in the posterior Rhinology, we were able to see a mass which was seen there. So the clinical diagnosis of hydrocortical polyp was made, and we took the scan. So as to our this thing, it turned out to be an hydrocortical polyp. We went ahead, we told the patient it was surgery, we took the patient for surgery as well. So during the surgery, what we saw, we removed the polyp. We can actually go to, you can see that there's quite an expansive lesion inside the maxillary sinus. It's entering into the nasal cavity here. You can see this is one end and this is the other end. It's through this opening, it has entered into the nasal cavity. Going posteriorly, you can see it is a ocular mass which is sitting here and occupying the entire nasal pharynx. That's why she ended up with a bilateral nasal obstruction at one point of time. But what happened during surgery after we completely excised the hydrocortical polyp? to our surprise, we saw an additional lesion there. So the lesion looked like an inverted papilloma. This was a diagnostic challenge for us. We, of course, the lesion was situated quite laterally. I reviewed the scan again on table. We didn't see any erosion of the bone around this area. So we couldn't have known that there was an inverted papilloma at this stage. But it already taken up, but we had to extend the procedure. We had to ask for doing a modified Denker's approach and take additional consents before we went ahead with the procedure. So when we went back and we checked the Hounsfield units here, so what we noticed that inside the polyp, the Hounsfield units were much lesser, it was in 125, 130. But when we came a little lower down in the area of where we saw the inverted papilloma, the Hounsfield units were more. This was one of the learning lessons or experiences, or one of the challenging situations which tells us that CBCT is not the ultimate, and there is definitely a scope for other radiological modalities as well. So especially if you are seeing opacification on one side like this, quite homogeneous, there could always be a second pathology there. Okay. Yes. Yes.
I just want to tell you, especially
This year.
yeah. See,
This area, when you are getting an artifact like this, see, you see this image homogeneous. When you have this kind of image, if you measure the picture, you will get this into this. See, if you look at it, right, you see the band. You see this? There is a difference. See this here? This here. That's why. So, very important to identify the limitation. That's,
In societal view, you can see the mass which is occupying the nasopharynx, and almost there's an air shadow all around here, which is telling me it's not rising from anywhere there, because I can see a shadow there. If I run through like this, I'm able to see a small air shadow here and here. So it's basically a mass which is coming from the paranasal sinus and occupying the nasopharynx of the corona. So it gives us not so great soft tissue demarcation, but the bony demarcation is quite good. That is how I would put it as. One of the last scans we did this. So now a very similar situation. Patient actually came with an history of cough, which was not subsiding, and patient actually is an important person. This particular patient, so we went ahead with the scan, and we saw that this is actually a subsequent scan which was done maybe about 2 months. We had an earlier scan also. We didn't see so much of filling up inside the maxillary sinus, but in this particular scan, we see that the entire maxillary sinus there is opacification which was noted. So we went ahead, diagnosis of fungal rhinosinusitis was made. Even on endoscopy, we saw that there was fungal elements. But one thing in contrast, particularly, especially if we had an experience with the previous patient, we saw that whenever we had a homogeneous thing like this, we went and we also checked out Hounsfield units. Definitely, there were differences, but in contrast to a normal CT scan, the metal and shadows and the other prominent things were not appreciable in this particular scan. So it is, yes, a good modality to analyze your bones, but whenever there is a soft tissue demarcation and whenever you require more soft tissue demarcation, this may not be the modality of choice. But for a routine understanding, a routine, whether to for a diagnostic purpose whether what is the anatomical landmarks, how near you are to the skull base, what is the location of the important structures. Yes, you are able to make out with only CT scan, but it does come with some limitations as well. So that is what I wanted to say. And this particular scan, I want to go back and show you a small video of this particular thing. This is an image guided surgery. The same scans are uploaded onto our navigation machine. So basically, this is fast forwarded. You can see a big fungal ball occupying the entire maxillary sinus to maintain it vitally maxillary sinus oxygen. And we saw a huge fungal mass. We evacuated the whole thing. The patient is doing quite well post the procedure. They immediately became asymptomatic after these things. So definitely image guidance, its role in image guided surgeries is something which is noteworthy, especially for ENT surgeons. That's what most people are interested to know, whether your scans are compatible with the navigation machine. Only thing, there are certain ways in which you have to take the scan. Your slide thickness need to be very less. The navigation machine uses only axial cuts, so axial cuts need to be fed into the machine. The tip of the nose is a must. You should include the tip of the nose in scanning. If you have not done that, you will not be able to reconstruct your images. And of course, even MRI can be fed into the machine. It can mix up the CT and MRI together to create a different kind of image which will help the surgeon during their surgery. So, in conclusion, what I would say is CBCT is a technology that is going to stay. It is quite helpful for ENT practice in giving us certain basic information. But whenever a soft tissue demarcation is required, we may still depend on a contrast enhanced CT scan, an MRI, and the role of the regular CT scan can never be discounted. So that is how I would like to end my presentation. And my references, and I would like to take any questions. Classes directing through the questions. It was very clear, the clear way he expressed everything. So I can appreciate that, the way he presented. You can see that there are so many possibilities in the software. He measured the downstream use of the bone, the other structures, soft tissues. He measured the length of the stylosis. And he moved all the bones and he showed only the stylosis. As if in osteology class, we can hold only the temporal bone or the sphenoid bone. We can move everything and we can keep the temporal bone in front of the software and start rotating it without the bone in our hand. See, that's what the power of the software which the CBCT machine comes with. And we'll experience all that after the lecture in the software. So it is very fascinating when it's like playing the video game. It's so fascinating you can play the software. That is CBCT. The second thing was the image guided surgery. So this CBCT scans are compatible with the image guided surgery. When I purchased the CBCT, the first question I asked the company people is whether it is compatible with CBCT, compatible with the navigation. In fact, I took the scans, I filled it over the navigation and it was successful. Then only I purchased the machine. Not only it should be diagnostic for the surgeon, it should also be helpful during the surgery. That's what I mean. So image guided surgery. And you know, in image guided surgery, it includes the safety of safety for the surgeons and the patient, because we are working around the optic nerve and the rest below the people. So it's very important not to damage the areas. and that's the reason when the image is possible. So thank you, Dr. Shays, for the enlightening on those who are very clear. And one thing we could have also measured the volume. The volume, especially affects the sleep of the patients. Inside you can measure the volume of the nasopharynx, oropharynx, area of the soft pharynx, area of the hypopharynx, and what is the total volume, what is the maximum volume, which is the place where the minimum volume, the minimum constriction. Based on that, we can decide the surgical aspects and effectiveness or the that you are adding in. So, thank you. Now, the next speaker will be Dr. Suhas, and I welcome to the podium and we will speak on third dimension in the CBCT.
Before I start with my presentation, I will just try to add up on what Dr. Shreyas and now, Dr. Shreyas observed the on-speed unit deficits. With the naked eye, we could not discern the deficits. The scientific basis behind that is there are 56 shades of gray, which is clinician can identify. And human eye can only discern the 14 shades. Okay. So that's a takeaway point for you that what you're seeing in the gray scale there, the machine is going to do a different thing. The most important point that the planning pointed out is, now before, as a radiologist, before we start reporting on these scans, first thing we look for is errors. Now we definitely identify that there's a lot of noise in the region, which has masked the diagnostic approach. So these are the two important things when we are dealing with images with ratios. Okay. Now coming back to my presentation on how the third dimension has helped us in the dental field. I will showcase just like a couple of representations. Historically, we have been very comfortable with the intraoral and panoramic radios. People who have been practicing dentistry of my age, we relied extensively on these two dimensions. And we sort of intuitively concluded a lot of things and then realized later probably our intuitive conclusions are wrong. Or sometimes it became correct also because it could be a fluke. Whereas the third dimension, which has given us the input, gives us true indications of what is happening. So by the third dimension, what is we have achieved is we can the anatomical visualization is enhanced. There is a perception of depth as well as spatial resolution, and there is precision in the measurements 1:1. Now, Dr. Shays' presentation is highlight process measurement 1:1 measurement. Whereas if it was a two-dimensional imaging, there will always be because of the projection of the magnitude. Because the receptor is quite away, so as the distance from the receptor and object to the there is a magnitude. So all these are avoided with the inclusion of the third dimension. Now, where CBCT makes a difference in terms of 10 factors. One is the implant unit, which is anything in dentistry is medicine. Apart from that, endodontics, surgical procedures, scientific pathology, scientific financial. And lastly, the developmental factors are in the process of demonstration. We will first discuss with the implant process. What an implantologist, they would put an implant into the abdomen based on these two images. How they would do this? We have a steel ball, which you dimension. Now this steel ball is put in the area where we want to keep it in. And we take an image. Now we need the dimension of the steel. And in the image, we measure the dimension of the steel. So if the steel ball was 2.5 mm diameter, image it is 3 mm. And the magnification factor is added to magnify the height of the dimension as well as the width. The transition from here was the sectional imaging and panoramic images, which was again very infant stages. At that time, Dr. Anand was doing the implant assessment using CT. He had somehow liberated the process while in Bangalore was one of the 21% measurements for results. Even before 66. So that was the transition. Now we have come to the 3-dimensional. Now to just to give you a perspective here, the clinical, the right lower corner is the clinical image that the bone is being exposed. Now if you look at the shape of the bone and the dimension of the bone, the same is available in our face. So before you open up, you have an idea of the proper topographical presentation of the bones. At the same time, you have a tool which gives you measurement phase in the measurement of the bone unit. So depending on where you want to place the implant, before we can do a lot of scanning, sorting, whereby the precision of placing the subsequent implant improves tremendously. If you look at the panoramic image, that is a vital structure in the bone which holds the inferior level parasitical bone. So when you are placing an implant, we need to identify this structure. Identifying this has become very easy with the advent of ECGs. So marking vital structures and simulated implant results. Now once the scanning is done, you can identify the canal by moving the sections and using a marker. There is a tool with which you can trace the canal and mark the canal. In implant, it is important because there are some rules and regulations or instructions to make sure that this vital structure is not damaged. Now, for example, when you are looking at the implant placement, by thumb rule, it says the distance of the implant from any vital structure and minimum of 2 millimeters should be between 2 implants. Adjacent implants for placing, minimum dimension needs to be 3 millimeters. And when you look at the structure, adjacent structure, there is an adjacent tooth. And again, from the adjacent tooth bone structure, you need to have a minimum distance of 2 millimeters. Then from the cortex to the implant, you should have a minimum of 1.5 millimeters. The decision to choose the implant which you want to do depends on all these factors. Its distance away from the vital structure, away from the cortical bone, as well as from the adjacent tooth, as well as if you are placing more than one implant, it will be a limitation. On occasion, is it possible to measure this? Not possible. So there we need the CBCT image with the tools to do this. The other concept is the use of the hospital image. When we are placing implant, we want particle bones which are of the density. If the density is too thin or too coarse, then the design of the implant will be too difficult to change. So there is a tool which can give you the overall on-stage image. Now we need to get some clarity of on-stage image. In the CT machine, where the on-stage image are used, the accuracy is very high. Whereas here, the accuracy is low, but approximate. In fact, when you use the software, if you pops in a disclaimer, the measurement tool for on-stage, there is a disclaimer capture. It says this is an approximation of the on-stage image, but not a full image. That is because the soft tissue data is not captured here to the extent which is captured in the medical system. Using on-stage image, caution is not true on-stage image as mentioned to 6. Then surgical guides Now, surgical rates, as I mentioned, this is possibility to put a surface rendering. The 3D scan surface rendering, this gives us the advantage of the surgical technique. For novices in laryngology, or to make your work easier, what you do is you do a scan, take a surgical template, put the surgical template in the patient's mouth. The duration of the surgical template is certain, put a virtual implant in the software. So that gives you all the requirements, how much is the error for the particular mount, how much is the error from the guided surface. Everything is measured and the angle in which the implant has to be placed. Now, because not always the implant is placed vertically, the decision to angulate the implant is based on the amount of particle bone. Particle bone, whenever the tooth is removed, there is always a constant process of resorption. And the resorption is not uniform. It varies from surface surface and linear surface therapy. So the decision to make the angle at which the implant is placed is based on the available particle bone. And once you have discerned that, then you have a surgical template and you have made option there where the angulation is predetermined. All you need to do is take the drill, try to drill it in the same angle because you are not going to move on. Unlike in the ENT places where you have software for the guidance, here we don't have the software for that, but we get a surgical. In orthodontics, we have complete denture process. What is the common complaint with patients? The denture is not sitting properly. The reason for this is the denture base is not adapting to the target point. Because of many errors it will be recorded or in charges. Now, with the CBCT, there is a possibility of identifying where this air gaps. So what we do is we take the denture, we put it with the gradient sulfate, or we will eliminate the denture base with gradient sulfate. Make the patient wear the denture and take the CBCT. So wherever air pockets are there, you will see that the dark areas are. So these are the areas where the denture base is not approximating with the patient. So this is one application of CBCT by modifying the denture. Orthodontics, many dental colleagues are there. If you see this picture, where an infected canine is there, what would be your decision on moving for orthodontic treatment? If you analyze, the canine is slightly angulated, there is sufficient space between the radical and the equilibrium molar. So technically our assumption is very easily the canine can be guided downwards. Okay. The same patient, I take another section just by the difference of 0.15 mm. You cannot even imagine that thin section. By doing that, what you will know? You look at the apex epithelium. There is a dissection. Now this is not easily identified with a two-dimensional image. Even in a three-dimensional image, unless you run the sections this won't be identified. A favorable case becomes unfavorable. This is the advantage of sectioning in CBCT. And if you observe here, the section what you are observing here is not a true side of effect, but a powerful side effect. Only because of this code, we are able to identify minute changes in the visual pattern. The same patient on the opposite side. If you see here, the root is lacerated plus this is kind of hooked into the nasal type. So it is technically not possible to pull it down unless you tilt it downwards, which is not possible. So favorable becomes unfavorable. So in these cases, you can take a decision whether to remove it surgically or just leave it. if you look at the follicular space around the crown of the canine, it is not enlarged. So the chances of it coming into the follicular system is very unlikely. So I can just leave it like that. So these decision makings becomes easy with the use of right language. So again, spatial perception for understanding position of the patient. The picture above the crown of the impacted canine is very much behind the root of the lateral. So you cannot just pull it out, you need to straighten the tooth, get it in the space between the premolar and the lateral, then you have to put it in. This kind of visualization was not possible with other techniques. Those were the cases when the orthodontists would have started the process, but would have taken many years or the tooth not budged. If you use a lot of force, there is going to be resorption of either externally or internally. Then explaining to the patient about the consequences at a later stage. Whereas a CBCT scan is going to give us inputs on all these issues, where you can educate the patient about the favorable or unfavorable outcomes. Another case where, if you see the crown of the central incisor is completely resolved and angular, and it is kind of continuous with the alveolar. The same patient requires orthodontic treatment for the impacted. So the decision making for the patient process was in the orthodontic process, you are not going to touch the central or incisor because the moment you touch it, it is going to become nothing. So you educate the patient that this is the issue, and then you need to be treated. The advantage of the third time session neuroengineering orthodontics. Endodontics, the big change in CBCT. The conventional two-dimensional image, the first premolar, there is a very difficult. Why the convention? What we studied in anatomy is the premolar of illusion. But CBCT gave us input as there are three regions, the two upper roots and the lower. Which otherwise we could have. So when we are having this, we can also take the anatomy of the throat. So that we know that there are three canals particularly possible. Conventional two-dimensional not much to differ, looks more like iron. And then when the same CBCT is used, we see that there are three canals identified. And the same possibility of the problem. The only difference you can make out here is there is the root canal morphology now whether you decide to take it for the treatment or not, how do we decide? If you want to go to the root canal for this is you need to identify where the canal is. But we do not imagine absolutely not identify any. Okay. So reverse CBCT for this, we find that there is a training canal opening which is identified. Now this can be measured accurately. The position of this canal can be measured accurately. So you know that gravity opening is given up to the access time. Otherwise, what would happen is we will attempt to first glorifies and have destroyed a lot of good structure. Whereas here, the angulation and the distance. Very technically, we can just take the work to the palm. Successfully and automatically completed. Otherwise, it would have been an unfavorable case, we would have recommended for extraction and planned the implant. The resolution is lower, but then it becomes third-dimensional. This is going to when we see sections, we can see there is a presence of the lateral canal. By measurement, we can identify exactly at what point the lateral canal is activated. So in these cases, what we can do is we can take the soft catapulture, integrated catapulture. So we introduce the catapulture only in the apical portion where the lateral canal is there. And because we are using pressure in the catapulture, the lateral canal gets filled. If this was not identified, what would have happened? As a dentist, you have filled only the main canal, the lateral canal is there. After 3 months or 6 months, it becomes a focus of infection and the patient comes to with common. If you go back and see the radiograph here, it is impossible for you to identify the possibility of a lateral. Okay. Now, this is a situation where you have taken CBCT because of which you have identified a lateral. Otherwise, it is not possible. So, can we make it would say that all will get CBCT done? If you look at the outcomes, even if 1 in 10 cases you are able to identify this before the procedure, it saves you a lot of embarrassment related to this. So, one advantage is because the radiation is low, or endodontic procedures, even though you know your ability. This will give you additional benefits for those 1 or 2 embarrassing situations. Now, the study is a 2-dimensional image where there is a post to place to be together. Then you have visualization. In this case, you see that there is some amount of buccal cortical. The same is seen as a cylindrical area of reduced density. Okay. Now the complaint of this patient was pain. And when we go back to the 4-dimensional image, there is no periapical pathology disease. Right? But the patient is experiencing pain. So where is the source of pain? There is a dehiscence of it. Buccal cortical plate is completely distorted. Where did the dehiscence come and why is it so good? If you look at the clinical picture there is one faint line in the center. There is a fracture. Because of this fracture, there is a. Now, in the coffee break, couple of you wanted pictures about identifying. Now, identifying fractures, I'll come back to this after the next slide. Here, this is again the fracture, where the fracture is occurred because of trauma. There is a displacement of the different fracture fragments. So there, the distance is easily visualized and identified. Whereas in case of endodontic procedures, where you are looking at root fractures, unless there is separation of root fractures, it is very difficult to identify. So what I do is, to confirm the fracture, I have to visualize the fracture in more than 2 minutes. Minimum 2 minutes. So what I do is, I insert the technician. If you are suspecting a fracture, you use a bite of a cotton ball on the tooth which is suspected to be a fracture. You place it on the tooth, ask them to bite with pressure, then this is CBCT. When this is done, what happens is, because of the vertical pressure, if there is a vertical fracture, the fragments are going to go up. If the fracture is horizontal, then the pressure is going to compress the fracture. It becomes less visualized. So clinical input, whether you are suspecting a vertical fracture or a horizontal fracture, is absolutely input. Okay. So these cases, very difficult to diagnose. Many times we have had a case with one of our cases where myself and my wife, the doctor started complaining that she can clinically see a fracture, but radiologically I cannot. Okay. Then there is the second opinion where that radiologist says there is a positive fracture. The same scan, it is not a different scan, it is read by two different people. For me, I have made it a mandate that only if I see fracture in two planes, I will give it a success. The reason is, if I give as a fracture after visualizing one plane, in case it is an artifact of the remote fracture, the treatment would have been an extraction. Once the tooth is extracted, they say there is no fracture. Then again it becomes a point bone of contention why a fracture was given in the remote fracture. So it is difficult to handle situations where we are diagnosing fractures when the separation is not. So two take-home points: if you are looking at a vertical fracture, a pressure bite to separate the fragments. If you are suspecting horizontal or oblique fractures, without pressure. So this input is what we require from the clinician. Maxillofacial surgeries most commonly is used for the assessment of the proximity of the root of impacted teeth to the inferior lobe muscle. So this gives us a very good indication because we can mark the canal, we can see the canal is marked with red, we know the canal is either buccal or delivered to the tooth and its contact to the tooth. But at the same time, in terms of pathology, we know we can measure what is the depth, what is the width, what is the height. So we know how much of surgical exposure is with it. Traumas or hairline fractures are very easy in this CBCT system because there's a lot of parameters. So even small hairline fractures can be diagnosed. These are cases from kids who are being going for taekwondo classes. So after a couple of classes, they have been complaining about saying, on the face there is nothing wrong, but then radiologically 2D scans gave us no input. When 3D scans were done, we identified that there were hairline fractures in the hair. Same here again, the same patient with the anterior teeth there fracture which was identified from a CBCT. The destruction of bone osteomyelitis is also very easy to identify in CBCT scans. The sequestration can be identified comfortably and the diagnosis also is complete. So what are the challenges and limitations? As I said, radiation exposure, and when compared to the regular 2D image, it is higher, but when compared to other CT images, cost considerations for procuring the equipment, otherwise per scan it is affordable in this case, and the most valuable thing is limited operations, which cannot be supplied even with software. So in the road ahead, what we are looking is the integration of VRA CBCT interpretations, virtual reality, just like Dr. Shes mentioned about the surgical part. We are developing virtual reality where we go tour and we do electronics on virtual reality. We do the access strategy for the devices. This is what is developing. And then patient-specific treatments can also be done. Now, the sleep metal artifacts and the metal artifacts are what is not doing us. In Siddhartha University, we have a biomedical evaluation program where we have a group, startup group working as street buses. So we are working on softwares wherein we can impute the data, thereby making the data more nearer to the anatomical visualization than compared to the artifact visualization. That is one thing we are doing in our organization. So key takeaways here is when we are looking at the dimension, it gives us accuracy diagnosis. It's going to be a game changer, and we need to emphasize on the benefits and balance the plus and minus of the technology to effectively utilize it. Thank you. I will take any questions.
With CBCT, can we find the strength of the tooth, especially incisors? Because why I'm asking this question is, we do micro-regional surgery for open heart patients.
So when you put the laryngoscope, the suspended laryngoscope, it is actually sitting on the incisors, upper incisors. So if the strength of the upper incisors is less, then many times can take. So can CBCT help in these cases preoperatively? Can we assess the strength of the incisors?
Technically, it is not possible, but surrogately you can think of whether it is strong or not. One way how we can do a surrogate is looking at the angular bone which is present on the lateral parietal section. So if the angular bone is sufficiently with the cervical margin, then the root has sufficient bone support. If you are looking at the fracture of the tooth as such, then it depends on the age of the patient. Older patients, the tooth is breaking. Younger patients, the tooth is not breaking. It can take a lot of bending. That is the only surrogate we can do, but not to the extent where we can identify the strength of the tooth.
And the implanted tooth, the strength of that is equivalent to the normal.
It depends on how much of the bone is integrated into the implant surface. Where again it depends from patient to patient and the type of implant surface scoping method to use. If the bone integrates into the implant, it is as good as an ortho, it can function normally like any other. And it has the same problems like an ortho in terms of conditions. Just like you have a periodontitis, you have a peri-implantitis. So the problems are same. The advantages are also same.
So it is more than 6 months old implant. And it's integrated. Usually integrated is like credits are there, right? In that the bone is developed after 6 months is always developed. And so it doesn't, regarding of upper insides of what is saying. So upper part of bone you can see with the cross sections, especially the sensory sections. And if it is root canal treated, more bone are fracture because it is treated. That also you can identify or in this scan process with those chances are in those cases high chances are taken due to the extra pressure we take.
Yes.
Sir, one more thing. Otherwise, if you think that one, there is a splint available, the transparent splint, which is like extra added supports perfectly. And if you just with that, get the splint. You can make it in the lab.
Stephen said we use guards sometimes, but these guards can reduce the size of the mouth and it becomes difficult to.
Sir, guard and split and guard are both the same, but I'm saying it is 1 millimeter thickness and it is transparent. So just if a patient just wanted before after where you are, you can put it there.
Can that take the load of the suspension laryngoscope? The suspension laryngoscope is in the larynx, and to visualize the open cards, we will rotate the wheel, and slowly the suspension laryngoscope will go anteriorly, and all the weight of the equipment falls on the incisors.
It's just added strength, sir. It is a 1 millimeter thickness. We get a soft split and hard split. Hard split is always affected. So it's just added strength and avoid very good. We usually distribute the forces to the back also. That's how we.
We have a similarity. We have same time started last years.
Similar, but he's ahead of me.
Innovation we get for still the license to modify. I was proper the silicon integrator. It protects very well and trying to go laterally.
Especially with the dentogenic sinusitis. So what precautions usually dentists take, especially to go extraction? Do they take CBCT to know whether this patient is going to have a potential molar fistula?
That is not generally commonly assessed for. We assume that the roots are away from the surface. Very rarely, the root is inside the surface. That is the assumption. So, you break up the tooth. If there is a communication, if it is identified, then you focus switch. If the clinician fails to identify the oral communication, that percolates as a trauma. It's later in the process of the infection. The CBCT scan in terms of dental peripheral infections and maxillary sinusitis. Very commonly, we have observed that is after taking up reporting CBCT scans. Majority of the dental restorations, root canal restorations, especially first molars, second 3 molars, Invariably, in proximity before the sinus, invariably there is resorption of the sinus floor and there is inflammatory tissue in the sinus. Very common finding after CBCT scans. Otherwise, it was taken for granted to take out the tool, to allow the socket to fill, if you identify the opening, you put a stop. That was the trend. But this is going to do a lot of difference. Please surgical, if there is a scan available, it is easy to identify where it is and how much it is inside the sinus. Many times we have had examples where the root canal restorative material has reached the sinus. Received material from the apex, it has reached the sinus because the apex is inside the sinus. And by doing the root canal procedures, they make sure they touch the apex with the instrument. If it is not stopped exactly at the point, it perforates the sinus and then that perforation leads the root canal material to flow into the sinus. So that is seen as a foreign medicine.
I like to mention one more case also. Actually, we have been one persons who which had sinusitis pain that can actually patient was very simple diabetes and with the removal of the GP and the removal of with the even treatment. I think treatments are complete both the systems. The opacification is completely come down and the sinus is completely clear. This are also in cases of even treatments and cases of fractures. Is it better to remove the GP take a scan or
Whenever technically if you're looking for a fracture, if there is an option, remove the beta fracture and the crown, then send the person for CBCT. This is what I request all the people with whom I can communicate. But generally what happens is they find it the pain to remove the beta and they don't want to take that chance. So this is the clinician, but as a radiologist, I would want the tooth without any beta fracture or the crown, so that way I'm minimizing the artifacts. Yes, please. Bone fractures usually have displaced fractures to some extent, and because the fracture line is running across a larger area, in either one or the other sections you will be able to visualize the fracture. Bone fractures are not very difficult to whereas certain fractures are. Exactly. So that is where you need to take help from your clinical dentist. So you have you have a history of the trauma. And as I said, we need to look at two different sections. And then the modal artifacts, the trabecular pattern and the nutrient canals. These are the differentials we need to use. So, comparing the trabecular pattern with the immediate adjacent bone, we will be able to identify. And artifacts, they have a kind of pattern. For example, it is coming from crown. It is either semicircular or it is coming from metatarsal gland, which is straight. So these are patterns in the artifacts. Whereas the fractures will have an irregular pattern. So artifact will not have one line of one line. So these kind of irregularities we will indication is a fracture rather than action. Undisplaced fractures are very difficult to identify. Displaced fractures are very easy. Which one fractures? Yes, yes. Sorry. Sorry. Firstly, there is a fracture. We will not answer the question. Technology is not possible. If the CP only started to reach on us, we have the freedom of Endoscopy in so many planes, so many sections. Right now, I don't know in technology that time. Multiple textbooks are good. Textbooks are there. You don't need a textbook, you just remember the terms, so you just read the parts. There are so many articles, so many years ago, and on the life really. You just want to express something. Root canal perforations easily identifiable with CBCT because the pattern of your instrument is there in the can. The one is straight, uniform diameter. That is a given saying that it is a perforation.
How about the partition areas?
What is the partition? There again, the pattern of the fracture. Your file will invariably be parallel line, cylindrical line, the shape of your file. Whereas fracture will have a irregular there.
And in case of one there is a value kind of relation more to that. More to that service. So yeah, then it's scared to excavate them. Usually, because of worry about the own what we can do, whether we have to leave the fish there or we have to excavate.
Granulomas is fine. Granuloma, if it doesn't spontaneously resolve, maybe you can ask players to take it out. That is easy for us. If the socket is open, if you send in film immediately, through the socket you can take it. Through the system only you can take it.
Get out of the disease. So that we are assuring patient confidentiality. One is always element about whether creating living and which is again have to go to the second. So if all the dental I would say if the process of infection is not subsided and all the dental treatment has been done, then it is time to probably address the disease of audiology with the sinus. That's when you have to go ahead and get out this.
I think